Now today we are going to discuss a very important topic, that is about the regulation of blood pressure, that how blood pressure is maintained at a set point in a normal person and how the fluctuations in blood pressure are counterbalanced, right, and buffered towards the normal value. You see that normal blood pressure, as we know that blood pressure has systolic value. Let's suppose normally blood pressure is 120/80. Hypothetically, of course, everyone does not have 120/80, but this is an average blood pressure, 120/80 millimeter of mercury. Of course, the pressure which is 120 value, this is called systolic blood pressure. Systolic blood pressure. And the value which is down, that is called diastolic blood pressure, right? Now, systolic blood pressure mainly depends on cardiac output, and diastolic blood pressure mainly depends on total peripheral resistance. So first we have to talk about this thing, that how the blood pressure is, systolic blood pressure is mainly dependent on cardiac output. So we can say systolic blood pressure is directly proportional to cardiac output, and diastolic blood pressure is mainly dependent or proportional to the total peripheral resistance. So first we'll make this concept that how the changes in cardiac output affect the systolic blood pressure, how the changes in TPR, total peripheral resistance, affects the diastolic blood pressure. Let's suppose here we have a person and this is his left heart. Now suppose this is your vascular system, and major artery break down into arterioles. And you know, arterioles have a lot of muscles. Arterioles have a lot of smooth muscles. These are the major resistance vessels. Right? Now, when left ventricle contracts, right, naturally what will happen, that mitral valve will close and aortic valve will just please open. So when left ventricle is contracting, after the isovolumetric contraction, aortic valve will open, right? And when aortic valve will open, the pressure will be coming from the left ventricular chamber and push into aorta and major vessels. Now this pressure which is coming to the major vessels, it will stretch the major vessels. And when it will stretch the major vessels, right, this pressure will stretch the major vessels, right? Let's suppose one of that is the aorta, and of course its major arteries also, branches. This pressure during the systole, during the systole, because aortic valve is open, so arterial tree and and the ventricular chamber, they are fully communicating. So pressure of the ventricular chamber are very faithfully transmitted to the pressure in the major vessels. So you know that the maximum pressure on average in ventricular cavity may be 120 millimeter of mercury. If in this particular patient, at the peak of the systole, if maximum pressure achieved in the ventricular chamber is 120 millimeter of mercury, then same pressure will be transferred to the arteries, and this pressure which is applied on the artery, that is also how much? 120 millimeter of mercury. Now from here we can infer another thing. Look, if we increase cardiac output, it means more blood is pumped during systole to the, so it will be more stretched. So to collapse it, you need more pressure. So it means the blood pressure is more again. Whenever cardiac output will increase, right, it means that per minute the blood which is pushed into arterial tree is more. So naturally with every systole, what will happen, that there will be more pressure achieved in the major arterial tree, and we say systolic blood pressure will go up. That is due to increase in cardiac output. Opposite to that, let's suppose if heart is becoming a weak pump, it is under negative inotropic influence or negative chronotropic influence, and its cardiac output drop. When cardiac output will drop, that amount of blood per systole which is thrown into major arterial tree is less, and if cardiac output is less, then the pressure which is induced by the heart to the arterial tree is also less, and what will happen, that systolic blood pressure will go down, and this will happen when cardiac output is down. So we can say that systolic blood pressure is the pressure in the main arteries present at the moment when heart is passing through the systole. When heart is at the peak of the systole, the pressure which is recorded from the major arteries like brachial artery is called systolic blood pressure. That is the moment when ventricular pressures are transmitted to the arterial tree. Is that right? And it's very easy to understand that if cardiac output is less, then pressure during systole will be less. And if cardiac output is more, then pressure during the systole in the major arterial tree will be more. Now you imagine that systole is completed. When systole is completed, naturally ventricle will start relaxing. When ventricle will start relaxing, there will be beginning of diastole. Now, during the diastole, intraventricular pressure start dropping. Intraventricular pressure is dropping rapidly. When intraventricular pressures are dropping rapidly, then naturally the blood which is present in this elastic artery will try to recoil, and column of blood will try to move forward as well as backward in both directions. Again, let me repeat. During systole it was filled. When during systole it was filled and straight. During diastole, when pressure in the ventricular chamber are dropping and ventricle is no more working as a pump for this tube, and this tube is elastic artery. So what will happen? Elastic artery will recoil, and when it will recoil, it will push pressure on the column of blood, and now column of blood will try to move backward as well as forward. But the anatomy of the aortic valve is such that when column of the blood try to go back, aortic valve will close. Now aortic valve closes during diastole, ventricular diastole. Now this point is very important to understand. We say that ventricle is undergoing diastole, aortic valve is closed. It means the relationship between the arterial tree, the communication between the arterial tree and ventricular chamber is cut off. That is, this is cut off. It is broken down. So it means when during the diastole, when aortic valve closes, the rapidly falling intraventricular pressures are no more related with the arterial tree. And now whatever pressure will remain in the arterial tree, that is called diastolic pressure. What is diastolic pressure? Diastolic pressure is diastolic blood pressure is said to be the pressure in the major arteries when heart is undergoing diastole, and that is the moment when aortic valve is closed, and even though ventricular pressure may be very rapidly falling, but whatever changes are coming into ventricular chamber pressure, right, those pressure changes are not influencing the pressure in the major arteries. Now what will happen during this? During this what will happen, that it will squeeze the blood. When it will squeeze the blood, one thing which is there, that in spite of the fact, now aorta will be recoiling. Aorta will be recoiling during the diastole. Major vessels will move inward. They will be recoiling. Now when it is recoiling, it is squeezing the blood. Because aortic valve is closed, blood cannot go back. The only option, blood has to move forward. So it means during the diastole, blood pressure in the major artery is no more influenced by the ventricular chamber, and this blood pressure which is present over here is mainly dependent on one factor, that how fast the blood will leave the major arteries, go into more peripheral vasculature. For example, if these arterioles are dilated, during the diastole, when aorta and major arteries press the blood will very rapidly leave. If blood very rapidly leave to the capillary system from the arterioles, it means there will be less blood left here. So pressure here will be less. So during the diastole, right, if arterioles are very much dilated, it means arterioles are offering less resistance to the flow of the blood. Then due to elastic recoil, the blood will start moving forward, and as total peripheral resistance is very, very less, a big volume will shift out of the arterial system to the venous system, and diastolic pressure here will be low. But if we give a drug which is arterioloconstrictor, and this drug make it very, very narrow, this point, and if arterioles really constrict too much, then during the diastole, can blood run off? No, blood is trapped here. If I give a drug which is arterioloconstrictor, it means that arterioles constrict, and for the blood from major arterial system to go to the venous system, there is too much peripheral resistance offered. And if there is too much peripheral resistance offered, then blood will move very little out of the major arterial compartment, and blood will be maintained here, and when more volume is maintained here, the pressure here will be more. Is that right? So it means the pressure which is present in the major arterial tree during the diastole, that is called diastolic pressure. That is called diastolic pressure, which is normally supposed around 80 millimeter of mercury. And this was your systolic blood pressure, which was around 120 millimeter of mercury. Now about the diastolic blood pressure, if we give arterioloconstriction, it means we increase total peripheral resistance. If we do arterioloconstriction, it means total peripheral resistance is increased. If total peripheral resistance is increased, blood is trapped over here, and during the diastole, pressure will go up. Rather than 80, it may become 90 millimeter of mercury. Opposite to that, if you give arteriolodilator, if you dilate all these peripheral arteries, you do arteriolodilation, what will happen? Total peripheral resistance will decrease. And if total peripheral resistance will decrease, then blood will rapidly shift from arterial tree to other compartment, capillary and venous compartment, and pressure here will be low, and maybe this value of 80 will come to 60 millimeter of mercury. The purpose of whole this diagram was to put in your mind forever that if you change cardiac output significantly, you fluctuate the systolic blood pressure. And if you change total peripheral resistance too much, you mainly alter the diastolic blood pressure. This concept is clear? That systolic blood pressure is dependent mainly on cardiac output. Diastolic blood pressure is dependent mainly on total peripheral resistance. There are other minor factors also, but this is the minimum you are supposed to know very well, right? It means that if we want to change the patient's systolic blood pressure, we have to change the cardiac output. If we want to change the diastolic blood pressure, it means we have to change the total peripheral resistance. If we want to change systolic and diastolic both values, then naturally we have to adjust the cardiac output as well as total peripheral resistance. Do you have any question up to this? It's clear to you? Now we'll come to the next point, and that point is that what is the concept of mean arterial pressure? What is the concept of mean arterial pressure? Mean arterial pressure. Mean arterial pressure. Mean arterial pressure means that on the arterial side, during systole pressure is 120 and during diastole pressure is 80. What is the average of that? What is the mean of that? Right? So we know that, let's suppose this is a time scale. This is the time scale, and this is 0. This is 0.3, and here is 0.8 seconds. Is that right? Now we know that pressure during 0.3 is systolic. Is that right? And how much is that place? 120 millimeter of mercury. And during diastole is longer. Diastole is longer. The pressure during diastole, right? Systole is shorter, diastole is longer. Pressure during diastole is 80 millimeter of mercury. It means that is 80 millimeter of mercury. It means, now listen carefully, attention please. If we want to the mean arterial pressure, attention please. If we want to talk about the mean arterial pressure, we are saying that during systole it is 120, during diastole it is 80. If you want to the mean should be somewhere less than 120 or more than 80 millimeter of mercury. Is that right? Mean pressure during the cardiac cycle within the major arteries. Now, how you can calculate? One thing is clear, during diastole blood pressure here is 80, and during systole blood pressure is 80 plus 40, because during systole is 120, 120 means 80 plus, what is extra pressure there? 20 millimeter of mercury. I think my calculation is not that good, 40, because the difference total here is 120 and here it is 80. So it means that systolic blood pressure is diastolic blood pressure plus additional pressure. So we can say 80 millimeter of mercury is maintained throughout the cardiac cycle, but during systole there is additional pressure. During systole there is additional pressure. So because systole is 1/3 of the total cardiac cycle, look here, systole is 1/3 and diastole is 2/3 of the total cardiac cycle. So this 40 should be divided into systolic as well as diastolic time, or simply we can divide the 40 by 3, and that becomes about 13 millimeter of mercury. That becomes about 13 millimeter of mercury. It means the average pressure or mean pressure should be 13 throughout, and when you add 13 to here it becomes 93 mean pressure. This is systolic pressure and green one is diastolic pressure. But if you make mean arterial pressure, that is diastolic pressure, is that right, plus 1/3 of systolic pressure, that is about 93 millimeter of mercury. Is that right? For practical purposes, let's assume we have a patient whose mean arterial pressure is 100 millimeter of mercury, and we'll see how body is maintaining the pressure. So now you understand the concept of mean arterial pressure, that is the diastolic blood pressure plus 1/3 of systolic blood pressure, that is the mean arterial pressure which is maintained throughout the arterial system. Here I also want one more concept to clear. You know, some students confuse mean arterial pressure with the mean systemic pressure. Do you know the difference between mean arterial pressure and mean systemic pressure? There is a concept called mean arterial pressure and there is mean systemic pressure. Mean arterial pressure is usually around 100 millimeter of mercury, and mean systemic pressure is about, it is 93 to 90 to 100 millimeter of mercury. Mean systemic pressure is around 6.5 millimeter of mercury. Now we must have a clear concept how they are different. Mean arterial pressure means the pressure only on the arterial side. Mean arterial pressure is pressure only on the systemic arteries, it is very high. But when we say mean systemic pressure, it means the pressure on arterial side, capillary side, venous side. Now mean arterial side has a high pressure, that is 100. But when you come to the add to the capillary and venous, the total pressure falls. Is that right? So mean systemic pressure is far less than the mean arterial pressure. Mean arterial pressure is the pressure which is maintained on the arterial side in a healthy person. But mean systemic pressure is pressure on arterial side and capillaries and venous, whole systemic circulation pressure, right? Average. Now here I want to tell another concept. Another way to understand the mean arterial pressure is that if you stop your heart, attention please, if you stop your heart, right, and after that whatever average pressure is left on systemic circulation, that is called mean arterial pressure. Write it down. What is mean arterial pressure? Conceptually, the mean arterial pressure is the pressure maintained in the, mean systemic pressure, please correct. Mean systemic pressure is pressure maintained in the systemic circulation, right, when there is no cardiac output, heart is not working as a pump, but still some pressure is maintained because blood is present in cardiovascular channels, and that is very low pressure, that is 6.5 millimeter of mercury. Am I clear?
You can repeat please.
Mean, there are two things, mean arterial pressure and mean systemic pressure. Mean arterial pressure is pressure which is present in the arterial side, which is a high pressure system, or mean arterial pressure. When we talk about mean systemic pressure, then actually when we talk about the mean systemic pressure, we are talking about that if heart is not working, still after that whatever pressure is left in cardiovascular system, that is called mean systemic pressure, and that is very low pressure, and this is the pressure which maintains the venous return. Write it down. This is the pressure which maintains the venous return to the heart, and mean arterial pressure is the pressure which maintains the flow towards the tissue. What a beautiful concept. That mean arterial pressure is this is the pressure which is maintaining the blood flow to the tissue, and mean systemic pressure is the pressure which is maintaining the venous return from the tissues to the heart. So if you make a diagram like this, okay, this is a very naughty marker. Again, let me tell you, let's suppose this is the left heart and this is your arterial system, and from here then we say capillaries and venous system. Now look, when we talk about mean arterial pressure, look here, we are talking about only this. Is that right? Mean arterial pressure, major arterial pressure. But when we talk about mean systemic pressure, we are talking about all the pressure from this side and all, even this pressure, and we are talking about the mean of all the pressures up to here, which are maintaining the venous return. Now look at the beauty of concept. Mean arterial pressure is responsible to keep the flow to the tissues. Mean arterial pressure is responsible to keep the flow to the tissue. But mean systemic pressure is responsible to maintain the flow towards the heart back. So from the left heart to the tissues, mean arterial pressure. From the tissues back to the right heart, blood is pushed by the mean systemic pressure. Is that clear? I hope you will not confuse these two things with each other when MCQ is there. If they are talking about mean arterial pressure, you have to talk about some value around 100. And when we are talking about mean systemic pressure, we are talking about some value which is around 6 or so. Is that clear to everyone? Thank God. Now we come to different variables which affect the cardiac output and heart rate, which will eventually affect the blood pressure. Now we know that blood pressure is a product of two values mainly. Now look here, this is blood pressure. Our blood pressure is maintained on what things? It mainly dependent on two things. Yes, cardiac output and yes, total peripheral resistance. And of course there is no fun in telling that cardiac output mainly controls which side of the blood pressure? Yes, systolic, mainly systolic blood pressure. And total peripheral resistance is controlling mainly which side of the blood pressure? Yes, diastolic blood pressure. Why I am repeating it again and again? Because it's worth repeating. Is that right? Why it is worth repeating? Because whenever we talk about the drugs which change the cardiac output, you think of changing the systolic blood pressure. Whenever we talk about in pharmacology the drugs which change the total peripheral resistance, we are talking about the drugs which are altering diastolic blood pressure. Right? Now, cardiac output you already know, it depends on many factors, but still three basic parameters are that number one, preload. Right? Preload. Preload is the amount of blood which is present in the ventricle just before the contraction of the ventricle. Right? That is the end diastolic. Preload is end diastolic volume or end diastolic pressure or this is simply the pre-stretch on the myocardium just before systole. Is that right? Second factor which influences the cardiac output is, yes, that is contractility. That is contractility, right? Because not only left ventricle should have end diastolic volume, but left ventricle should also have the capability to contract, right? It should have a capability to develop some strength and tension in its wall and contract and produce the pressure, so that cardiac output should be, stroke volume should be thrown out of the ventricle. So we can say it depends on preload, right? It depends on the contractility, and it also depends, cardiac output also depends on afterload. It also depends on afterload. And afterload is what? The resistance against which left ventricle has to pump, and that is what? Aortic pressure. Is that right? Which of course primarily depends on total peripheral resistance. I will not go into detail of these factors, but I will just talk about few things. That preload depends on what things? Preload depends on, number one, mainly depends on end diastolic volume. That mainly depends on end diastolic volume, which I have already written at the top. Now, end diastolic volume depends on what? End diastolic volume depends on two things. Number one, venous. Yes, what is that? Venous return. End diastolic volume depends on what? What is the venous return? Venous return. And venous return depends on what? Yes. Venous return depend on? Yes. Right atrial pressure, or we can say that venous return depends on, okay, right atrial pressure, right, and which itself depends on venomotor tone and blood volume. Venomotor tone and blood volume, right? If you have more blood volume, venous return will be more, preload will be more. Cardiac output depends mainly on two basic things. You can make a little modification here to that. Cardiac output depends on stroke volume and, yes, heart rate. Cardiac output depends on stroke volume and heart rate, and stroke volume primarily depend on preload, contractility and afterload. Is that right? Now, what we have to learn here, that if your blood volume is increased, then venous return is increased, right atrial pressure is increased, venous return is increased, end diastolic volume is increased, preload is increased, stroke volume is increased, cardiac output is increased, blood pressure is increased. It's so simple. Another factor is the filling time. Other factor is the not only filling pressure, right atrial pressure is the ventricular filling pressures. We have to also talk about the filling time allotted for filling of the ventricle, right? Of course, that is diastolic interval, right? Now, we'll discuss this. Look here. If blood volume is less, now don't write, just concentrate on. If blood volume is less, filling pressures are less, venous return is less, end diastolic volume is less. Of course, preload is less. According to Frank-Starling's law, stroke volume will be less. If stroke volume is less, cardiac output is less. If cardiac output is less, then systolic blood pressure drops. And if you do reverse, that if blood volume is increased, for example, if you are giving blood transfusion or if you are giving normal saline, right, or any other fluid which maintains the higher volume of the blood. If blood volume is high, then what will happen? Filling pressure to the heart will be more, and diastolic volumes will be more, preload will be more, stroke volume will be more, cardiac output will be more, and blood pressure will be more. Is that right? Now we relate it with venomotor tone. That if venomotor tone is more, if venomotor tone is more, it means veins constrict. If veins constrict, then venous return will be again more. If I give you a drug which is venoconstrictor, so when veins constrict, lot of blood which is pulled into veins will be pushed back to the heart. So if venomotor tone is more, filling pressure will be more to the ventricle, of course venous return will be more, and diastolic volume will be more, preload will be more, stroke volume will be more, cardiac output will be more, blood pressure will be more. And if you give a drug which is venodilator, for example, if you give nitrates to your patient, which are venodilators, if you give venodilators, veins will dilate, they will accommodate and pool more blood, so filling pressure which maintain the venous return are less, venous return to heart will be less, and diastolic volume will be less, preload will be less. If veins dilate, preload will be less, stroke volume will be less, cardiac output will be less, and blood pressure, especially systolic blood pressure, will be less. Is that clear? So what we can see now here about the another factor which determines the venous return. Because venous return, that what is the pressure for the return, and diastolic volume also depend that how much is the diastolic filling time. Normally if your heart rate is 72 beats per minute, then contractility time is 0.3 second, which is systolic interval, and diastolic time is 0.5 second, which is diastolic interval. Now, if filling time is more, then ventricle will be appropriately filled. But if you keep on increasing heart rate, then with very progressively increasing heart rate, eventually diastolic interval becomes so small that filling times are so much reduced that venous and diastolic volume is reduced. Again, let me explain that if your heart rate is very, very fast, then diastolic interval will shrink. If diastolic interval is very less, in spite of the returning pressures, because filling time is less, it will not work well. So end diastolic volume will be less. And if end diastolic volume is less, preload is less, stroke volume is less, cardiac output is less, blood pressure will be less. What does it mean? That when you increase the heart rate, initially cardiac output goes up. But if your heart rate is so much increased that diastolic interval becomes dangerously small, then ventricle cannot be filled well. So under those circumstances, in spite of high, you can say, heart rate, stroke volume becomes so less that blood pressure will fall. Am I clear? Do you have any question? No, you are clearly understanding. Now, after having said this thing, that cardiac output depends on stroke volume and the heart rate, it also depends, stroke volume depends on contractility. We have already discussed the positive inotropic factors and the negative inotropic factors. If myocardium is healthy, it contracts well. If myocardium is given digitalized, right, digoxin is given to the patient, contractility is more and stroke volume will be more, cardiac output will be more, and blood pressure can go up. But if there are some influences which inhibit the contractility, for example, you are giving negative inotropic drug, or contractility is reduced due to severe, large, massive myocardial infarction. So there is less healthy myocardium is available in a smaller amount because big piece has been infarcted. Then total contractility of ventricle will be less. Or you have acidosis, or you have some electrolyte disturbances which suppress the myocardium. Then again contractility is less. So whenever contractility is less, stroke volume is less, cardiac output is less, and systolic blood pressure is down. Is that right? Now we come to the afterload. Afterload is the resistance against which heart is working. When arteriolodilatation occurs, afterload is less, because if you give a person arteriolodilatory drug, then it means that arterioles will dilate, total peripheral resistance will become less, heart will be beating against less resistance, right? And when afterload is less, then stroke volume will be more, and cardiac output will be more. And opposite to that, if your afterload become too high, if afterload become too high, then cardiac output is inversely affected, because if afterload is too high, then heart cannot pump against high resistance and stroke volume will drop and cardiac output will drop. Now another thing is heart rate. Heart rate also affects the cardiac output. As you know that cardiac output is equal to stroke volume into heart rate. So as you keep on increasing the heart rate, cardiac output keep on increasing, but up to a limit. I've explained it previously. When heart rate becomes so fast that diastolic interval will become too small, then increase in heart rate will be associated with dangerous reduction in stroke volume, and then further increase in heart rate will be associated with dropping of the cardiac output. That is why some people who have dangerous tachyarrhythmias, their blood pressure start falling. Is it clear? Then we were talking about that blood pressure depends on total peripheral resistance and mainly diastolic blood pressure, and you know total peripheral resistance is mainly determined by the arteriolar tone, because arterioles are the major resistant vessels, right? They resist the movement of the blood from the arterial side to the venous side. So major resistance is offered by which vessels? Arterioles. And if you have any factor which lead to generalized arteriolodilatation, total peripheral resistance will drop and diastolic blood pressure will drop. And if you are giving a drug which is a strong arterioloconstrictor, then from arterial side blood cannot shift easily to the venous side. So trapping of the blood, stressed volume of the blood, you know blood has two volumes. Some volume of the blood is trapped on the arterial side, but most of the blood volume is trapped on the venous side. The amount of the blood which is trapped on the venous side, that is called unstressed volume. Should I make a diagram or you know it? Let me make a diagram. This concept should also be clear, that this is the arterial system, and let's suppose through the capillaries this is coming venous system. Now listen, the blood which is trapped on the arterial side, it is under high pressure or low pressure? Under high pressure. So this volume of the blood which is present here, it is under stress. Opposite to that, blood which is present on venous side, do you think it's under high pressure or not much pressure? Not much pressure. So we call it unstressed volume. For example, if you have 5 liters of blood, it is approximately, it's just an approximation, that maybe 4 liters of blood is present on the venous side, and suppose about 1 liter is present on arterial side. Of course, it's not very much approximate. Now, if you have 4 liter blood here and 1 liter on this side, so 1 liter which is on the is arterial side, we say this is a stressed volume, and 4 liter of the blood which is present on the venous side, this is called unstressed volume. Now the real pressure is maintained by the stressed volume. Real pressure in cardiovascular system is maintained by the stressed volume. Now listen carefully, something very interesting. If you keep on increasing stress volume, blood pressure will go up. If you keep on decreasing the stressed volume, blood pressure will go down, because you measure the blood pressure on the arterial side. Do you measure the pressure on the venous side? No. Systemic blood pressure which is measured here, that is on the brachial artery, not brachial vein. That is the pressure in the brachial artery. Now, so volume which is in the major arteries, arterial side, this is called stressed volume, and volume which is on this side, this is called unstressed volume. Now another concept here. If you do venoconstriction, then unstressed volume, a part of the unstressed volume will shift to the stressed, and your blood pressure will go up. But if you do venodilatation, right, then less blood going towards the stress, but from the stress more coming here, so blood pressure will fall. In the same way, we can also regulate the blood pressure by arterial system. If you constrict the arterioles, stress volume will be trapped more. If you do arterioloconstriction, stress volume will be more, because venous side will throw to the arterial side. From arterial side, blood cannot come to this side if there is strong arterioloconstriction. So when you do arterioloconstriction, right, when you do arterioloconstriction, what really happens, that pressure stress volume become more, right, and when stress volume will become more, blood pressure will go up. But if you do venoconstriction, right, that will also increase to that side, and what will happen, stress volume will again become more. So what we really learn here, that venoconstriction shift the unstressed volume to the stress. or arterioloconstriction does not allow the stress volume to come to the unstressed. Both conditions increase the stress volume, both of them will take the blood pressure up. Opposite to that, as I told you, if you do venodilatation, unstressed volume is more, right? Less is going to that side, stress volume is becoming less. Or even if you do arteriolodilatation, from the stress side, unstressed side, more blood is coming. So either you do venodilatation or you do arteriolodilatation, both things lead eventually to the shifting of stress volume more to the unstressed, and blood pressure goes down. Is that clear? Any question about it? Now we have already developed the concept of mean arterial pressure, and that is equal to cardiac output into total peripheral resistance. Fine? Cardiac output into total peripheral resistance. Now one thing which is very obvious from this simple formula, that if cardiac output goes up, mean arterial pressure will go up. If total peripheral resistance goes up, mean arterial pressure will go up. But one thing which I want to make in your mind clear is that it's not so simple, because if you, let's suppose, if you double the cardiac output, mean arterial pressure will not double. Mean arterial pressure will not double. The reason being that when you double the cardiac output, right, actually total peripheral resistance will alter to adjust with that. So if you increase the cardiac output, total peripheral resistance will slightly decrease. So there will be increase in mean arterial pressure, but not the double increase. What I am trying to say, the cardiac output and total peripheral resistance are not independent variables, they are interdependent variable. If you increase one, other usually decreases. Is that right? Another example. If you double the total peripheral resistance, again mean arterial pressure increases, but not double. Why? Because if you double the total peripheral resistance, cardiac output decreases, right? Because afterload is increased. Let's suppose that total peripheral resistance increase too much, but the mean arterial pressure will increase moderately, not severely. If there's severe increase in total peripheral resistance, mean arterial pressure will be increased moderately, because when there's too much increase in total peripheral resistance, there is some decrease in cardiac output. So what I'm trying to say, that cardiac output and total peripheral resistance both affect the mean arterial pressure, but they are not independent variable, they are interdependent on each other. Usually under physiological condition, and one of them increases too much, then others decreases to some extent to counterbalance the effect of that on the blood pressure. Is that clear? Now, regulation of blood pressure has two very important concepts, that is short-term regulation of the blood pressure, and there is long-term regulation of blood pressure. Regulation of blood pressure. There's two types of regulation of blood pressure. There is short-term or rapid regulation of blood pressure, short-term regulation of blood pressure, and there is long-term regulation of blood pressure. Short-term regulation of blood pressure has many factors, but the most important is neurological regulation of blood pressure, neurological regulation of blood pressure. And long-term regulation of blood pressure depends on many things, but mainly it depends on Renin-Angiotensin-Aldosterone axis, right? And there are many other factors which are minor factors. The major factors, if you talk about the regulation of blood pressure, how your blood pressure is stabilized, because your biological system defends the major fluctuation in blood pressure. If my blood pressure is going up, then biological system will try to bring it towards the set point. For example, my blood pressure set point is 100 millimeter of mercury, right? My mean arterial pressure is, suppose, 100 millimeter of mercury, and we say 100 millimeter of mercury is my set point blood pressure. Now, if my blood pressure is progressively going up, then short-term regulatory mechanisms and long-term regulatory mechanisms will try to bring it back to the set point. So they will try to bring the blood pressure down. Opposite to that, if my blood pressure is progressively falling, right, then what will happen? Again, these regulatory mechanisms, right, they will try to bring the blood pressure back to the elevated to the So due to the presence of such mechanisms, these are the major mechanisms, and later on I will discuss there are some minor mechanisms as well, right? So due to these major mechanisms, right, what really happens that usually our blood pressure remain around a certain set point, right? To understand all this, how the neurological regulation of blood pressure occur, how the different reflexes control the blood pressure, right? We'll take one example. First, you can take an example of me, that if my blood pressure is going up, right, how the neurological system coordinate to bring the blood pressure down. And second example we'll take, if I develop hemorrhage and my blood pressure is going down, how the neurological system has a coordinated effort to bring the blood pressure up. Is that clear? Now, first we'll talk about neurological regulation, and we'll take two examples that how this will work if blood pressure going up. This scenario I will discuss first, right? And then as a second part of this discussion, I will talk about if my blood pressure is going down, how this will respond. Because purpose of this is to defend the blood pressure, to maintain the blood pressure. If there are major fluctuations in the blood pressure, it has to defend the fluctuations and maintain the blood pressure around normal values. Now, first I will talk about if my blood pressure is going up, how it will stabilize it. Let me give you some examples. Now, nervous system is involved in this regulation. Diagram, and then we will talk about this factor. Let's suppose this is your heart, and here is your circulatory system. Of course, in the heart, here is your SA node, here is your AV node, Purkinje system. Now, what we need to understand is that major fluctuations in blood pressure, how they are counterbalanced by the nervous system, right? Here is your central nervous system. Midbrain, pons, medulla, spinal cord, right? This is frontal view of central nervous system. Now we have to see that how really the system works. Of course, you must be knowing this is spinal cord, and here is the section of spinal cord. Now, what really happens? That here is your aortic outflow, and here is your, okay, I will make it like this, major blood flow. This is internal. Now, I don't want to see this coarctation there. Now, let's see what really happens. Actually, there are blood pressure sensors. There are blood pressure sensors present in cardiovascular system, right? There are volume sensor on the venous side and pressure sensors on the arterial side. Right now, I will talk about the pressure sensors. Actually, let's suppose this is carotid sinus. I will make it larger. Suppose here is carotid sinus, right? This is internal carotid artery. Now, in the adventitia of carotid sinus, there are some nerve endings, and these nerve endings are acting as baroreceptors. Baroreceptor means pressure measuring device. These are acting as pressure measuring device. And these pressure measuring devices, right, these are actually connected with the ninth nerve. Which nerve? Ninth nerve. Ninth nerve is, this branch goes to the ninth nerve, that is glossopharyngeal nerve, ninth cranial nerve, right? And this branch which is going to the ninth cranial nerve, this is called carotid sinus nerve, carotid sinus branch. So we can say glossopharyngeal nerve through the carotid sinus branch is connected with the carotid sinus. Now, this nerve is going to take information to the medulla. This is going to take the information to the central headquarter, to the medulla. Now what really happens? This is one neuronal input to the CNS. Another neuronal input is from the aorta. There are baroreceptors in aorta also, right? And they are also taking the information to CNS, and that is through the 10th cranial nerve. And 10th cranial nerve is vagus. So we can say 9th cranial nerve is taking information about the blood pressure from the carotid sinus, and 10th cranial nerve is taking the information about the blood pressure from the aorta. Is that right? Now, through the 9th and 10th cranial nerve, information is going to the medulla. Now what really happens? Let's suppose my blood pressure start going up. Suppose my blood pressure is going up, right? If my blood pressure is going up, what really happens? Look here, that these aorta will be more stretched, and even this will be also more stretched. So when the suppose carotid sinus become more stretched with the high pressure, because this increasing pressure, right, blood pressure will open, stretch these arterial sites more. When this arterial site will stretch, then these nerve endings will be also stretched. Let's suppose we make a daughter diagram. I don't know how people determine the gender of a diagram, but anyway, suppose this is the carotid sinus. Now here is the nerve ending. Now what really happens, that this nerve ending at the end has sodium channels. It has some, which channels? Sodium channels. Now, when blood pressure will go up, when blood pressure is up, naturally it will stretch the vessels more or less? More. When the vessels will be stretched, of course vessel wall will be stretched, and when vessel wall will be stretched, look, then this nerve ending will be stretched, and when this nerve ending is stretched, these channels will open more. So more sodium, of course the extracellular area is rich in sodium, so more sodium influx will occur. If more sodium is entering in, this will be becoming a sort of depolarizing current. So resting membrane potential of this nerve ending will become more near to the threshold, and it will start producing action potentials. So first point which you have to understand how the baroreceptors work. Baroreceptors are the specialized nerve endings which are also called mechanoreceptors. These specialized nerve endings have mechanically regulated sodium channels. Which channels? Mechanically regulated or stretch regulated sodium channels. So when blood pressure goes up, these nerve endings, when blood pressure goes up, arterial side is stretched. When arterial side is stretched, that will lead to the stretching of the nerve ending. And when nerve ending is stretched, more sodium influx will occur. More sodium influx will occur, resting membrane potential will become more near to the threshold. For example, this was its resting membrane potential, this is threshold potential. So as more and more sodium comes, resting membrane potential is becoming more near to threshold. So we can say this is depolarizing current. So increasing the blood pressure stretches the carotid sinus. More stretch in the carotid sinus stretches the nerve ending. Stretch of the nerve ending produces depolarizing current, and depolarizing current take the resting membrane potential to threshold potential, and now these nerve endings will be producing more action potentials. These nerve endings will be generating more action potential. So it means that firing of action potential firings from these nerve endings will increase when blood pressure goes up. And right now I would love to discuss that if due to any reason your blood pressure is going down, it means stretch on the carotid sinus is reduced, it means these nerve endings are no more stretched. If they are no more stretched, then sodium influx will be less and depolarizing current will be less, and action potential firing by these nerve endings will be less. You understand it? So what we say that these are specialized baroreceptors and nerve endings which are present in the carotid sinus adventitia, as well as these are present in aortic arch. And in both places they are working in the same fashion, that whenever blood pressure goes up, they are overstretched. Whenever they are overstretched, there is more depolarizing current in them. Whenever there is more depolarizing current in them, more depolarizing current generates more frequency of action potential. So more frequency of action potential report to the central nervous system, right? And there this message is higher frequency of incoming action potential through these two neuronal pathways interpreted as blood pressure is going up, right? And there is a central regulator who will orchestrate the response. Now, central regulator is a very special type of nucleus here. Now, can you tell me this nucleus? This is actually in the medulla. This nucleus is mainly in the medulla. Do you know the name of this nucleus? Because actually this information which is coming, it has to come to this nucleus, and this incoming information, when it will come to this nucleus, this will report to this nucleus that blood pressure is going up. Is that right? They will bring the information that blood pressure is going up. Right, now this nucleus has to produce the output. What is the name of this nucleus? Yeah? What is the name of this nucleus? This is nucleus, you know it, the name, nucleus of Tractus solitarius. Have you heard of it? Nucleus of Tractus solitarius. So what is this nucleus? This is point number 1, and 1 is nucleus of Tractus solitarius. So we can say that baroreceptor in the carotid sinus and the aortic arch, these baroreceptors, right, through the buffer nerves, these nerves are also called buffer nerves because they buffer the blood pressure fluctuations. So through the buffer nerves, they inform the Tractus solitarius nucleus with all the changes in the blood pressure. Now this nucleus has to coordinate the response. This nucleus has to coordinate the response. Now how this nucleus is going to coordinate the response? I told you this was Tractus solitarius nucleus. Right? Now when it receives the information that blood pressure is progressively going up, it has to decrease the blood pressure. To decrease the blood pressure, it's really intelligent nucleus. It's really intelligent nucleus. It knows what to do. What it has to do? Number 1, reduce the heart rate. Because if you reduce the heart rate, cardiac output will be less. And if cardiac output is less, then of course systolic blood pressure will go down, and of course whenever systolic blood pressure will go down, along with that mean arterial blood pressure will also go down. So first thing which is going to do is that this is cardio inhibitory center. What is this? This is cardio inhibitory center. This was nucleus of Tractus solitarius. Now this is cardio inhibitory center. We call it cardio inhibitory center. So what it will do? It will actually stimulate the cardio inhibitory center. It will give stimulatory signal to cardio inhibitory center. Cardio inhibitory center is mixing with the vagal nuclei, and then cardio inhibitory center will bring the information out, and this information will go to the SA node through the right vagus and AV node through the left vagus, and this information will inhibit the SA node. Of course, what is this pathway coming? This is right vagus, right? So we can say that one of the function it has to do is that this is going to stimulate what thing? what it is going to stimulate is cardio inhibitory center. So this cardio inhibitory center is connected with the vagal nucleus, and vagal fibers will be going towards the SA node, and vagus releases on SA node acetylcholine, and acetylcholine act on M2 receptors. You know that M2 receptors are connected within the SA node with G inhibitory proteins. Is that right? Intracellularly. And eventually what happens, that SA node will be inhibited. So it means now one response was, this is response number 1. There was activation of cardio inhibitory center or cardio decelerator center. Cardio inhibitory center fibers through the vagus nerve come to the SA node, reduce the heart rate. Now you know it, that if you reduce the heart rate, actually you reduce the cardiac output. And when you reduce the cardiac output, you reduce the blood pressure. This is one thing. Secondly, it will do one more thing. And what is that? This card, right? The second thing which it will do, that it will inhibit cardio accelerator area. There is cardio accelerator nucleus. It will inhibit the cardio accelerator nucleus. Now we have to see intelligently what it has done. That it has stimulated cardio inhibitory area, but it has inhibited, what is this nucleus? Cardio accelerator. When now normally how the cardio accelerator work? Cardio accelerator normally gives descending pathway fiber, and these fibers are connected with the lateral horn. And from here, postganglionic fibers, the postganglionic fibers go out, end up into sympathetic ganglion, and from this sympathetic ganglion, postganglionic sympathetic fibers are going to, what is this? SA node. Now what really happens? This is response number 2. That is sympathetic outflow. Now look here. What has happened? That parasympathetic outflow was stimulated, but sympathetic outflow is inhibited. So when cardio accelerator area is inhibited, when it is inhibited, then this whole pathway is inhibited. And when this pathway is inhibited, then it means the norepinephrine release on SA node is reduced. And when norepinephrine release on SA node is reduced, that further decreases the heart rate. And when there is further decrease in the heart rate, that will lead to what? Further drop in cardiac output. And that further drop in the cardiac output will be translated into what? Decreased cardiac output, decreased blood pressure. Is that right? Then another thing is another center, and this center is called vasomotor center. What is the name of this center? Vasomotor center. Actually, this center is also inhibited. This center is also inhibited. Right? These are all in the medulla and lower pons. Now, when this is also inhibited, what really happens? Okay, I'll continue. I'll draw here spinal cord. Now, this cardio inhibitory area, which is also downgoing fibers, actually these fibers will reduce. Look, when this is inhibited, Stractus solitarius has inhibited this. Okay, I'll put a special color to Stractus solitarius, because this is the nucleus which is the central coordinator of the blood pressure regulation. So what Stractus solitarius has done, it has stimulated vagal outflow, it has inhibited the sympathetic outflow to the heart, and now it has inhibited the vasomotor center. Right? What is this? Vasomotor center. Vasomotor center. Now when vasomotor center is inhibited, then the sympathetic outflow is inhibited, right? And this sympathetic outflow, when sympathetic outflow is inhibited, what really happens? this sympathetic outflow is inhibited, the neurons which are going to the venous side, they are inhibited, and neurons which are going to arterial side, they are also inhibited, and neurons which are going to adrenal medulla, they are also inhibited. What will be the result? That norepinephrine release is reduced on the venous side. Norepinephrine, because these are noradrenergic fibers, right? So these norepinephrine release is reduced. When norepinephrine release is reduced, that will produce venodilatation, right? And when you can say sympathetic supply to the arteriolar smooth muscle is reduced, let's suppose this is arterial smooth muscle, then it will lead to arteriolodilation. So what is the result? That blood pressure was going up. Is that right? When blood pressure was going up, baroreceptor increased the frequency of their action potential, which reported to the tractus solitarius that blood pressure is going up. Now, nucleus of the tractus solitarius system has to orchestrate the different cardio inhibitory center, cardio accelerator center, and vasomotor center, alter their activity in such a way that blood pressure should come down. One thing I told you, that this system will inhibit the this will stimulate the vagal outflow. It will stimulate the vagal outflow, and when it will stimulate the vagal outflow, what will happen? That vagus will inhibit the heart rate, cardiac output will be less, and blood pressure will come down. Secondly, it will inhibit cardio accelerator area, so sympathetic fibers going to the SA node will be inhibited. Even to AV node will be also inhibited. So when sympathetic activity is inhibited, it means heart is no more driven by sympathetic system. Again, further reduction in cardiac heart rate and further reduction in cardiac output, further drop in blood pressure. At the same time, it will inhibit the vasomotor center. So through the vasomotor center, the venoconstrictor fiber and arterioloconstrictor fibers, their activity will be reduced. When venodilatation will be there, it means stressed volume will increase. Venous return will be less or more. When venodilatation will lead to reduced venous return. And when there is reduced venous return, that will lead to reduced end diastolic volume, reduced contractility, and reduced cardiac output, and therefore again reduce the blood pressure. Is that clear? Then when the fibers which are going to arterial side, they no more constrict the arteries, so arterioles will relax. And if arterioles are too much relaxed, what will be the result? If arterioles are too much relaxed, total peripheral resistance will decrease. When total peripheral resistance will decrease, then what will happen? That blood from arterial side can easily go to the venous side and diastolic blood pressure will fall. Is that right? So in this way, plus it will do one more thing, that supply sympathetic stimulation to the adrenal medulla is reduced. So there is reduced release of epinephrine, and this epinephrine, which was a circulatory substance here, right? When epinephrine is reduced, then epinephrine induced cardio stimulation is reduced, cardiac heart rate is reduced, epinephrine induced positive inotropic action is reduced, and again cardiac output is reduced. Is that right? And epinephrine induced venoconstriction is reduced, so again venous return is reduced, and epinephrine induced arterioloconstriction is reduced, so again total peripheral resistance is reduced, and that will reduce diastolic blood pressure. So in a nutshell, now let's review it in a decent way. That let's suppose my blood pressure is going up. You have given me some drug which is slightly taking my blood pressure up. Whatever the reason, if my blood pressure is going up, which nerves will report to the central nervous system? 9th nerve and 10th nerve. 9th will take information from carotid sinus, and 10th nerve will take from aortic arch. How they will report? That increasing blood pressure will stretch the nerve endings more. More stretching of the nerve ending will produce depolarizing current more in the nerve endings. More frequency of action potential will be produced. When you can say action potentials are arriving with higher frequency to the tractus solitarius. This is the tractus solitarius, which will alter the activity, basal activity of different cardiostimulatory inhibitory areas and vasomotor tone. That once there's incoming action potentials are too fast, right, too frequent, tractus solitarius will stimulate the cardioinhibitory center, vagal outflow will be more, and heart will be inhibited. Number two, it will inhibit the, what it is doing, inhibit the cardio acceleratory area, so sympathetic drive to the heart is reduced, heart rate and is reduced, stroke volume is reduced. Then it will inhibit the vasomotor center, so what will be the result? That sympathetic major outflow is reduced, veins dilate, venous return is reduced, cardiac output is reduced, blood pressure reduces. Arterioles relax, right, when arterioles relax, again total peripheral resistance reduced, blood pressure drop. Then even stimulation to the adrenal medulla is reduced. So epinephrine level in the blood goes down, so epinephrine mediated venoconstriction is lost, epinephrine mediated arterioloconstriction is lost, epinephrine mediated positive chronotropic and positive inotropic actions are lost, and of course all these things will again reduce blood pressure. And one thing which I especially love to mention, that even there is sympathetic outflow which goes to kidney, and in the kidney there is JuxtaGlomerular Apparatus which has beta 1 receptor, and if JuxtaGlomerular, normally under the sympathetic stimulation JuxtaGlomerular Apparatus releases renin, but in this case when blood pressure is going up, right, then sympathetic outflow is reduced, so JuxtaGlomerular Apparatus is also not stimulated neuronally, right, and renin become less, and later on I will talk about that decreasing blood pressure also affect directly the Renin-Angiotensin-Aldosterone axis. Do you have you understood it clearly, or do you have any question about this? There's no question. Okay, let's do reverse. That if opposite happen, then what will be there? For example, if my blood pressure is going down, I develop hemorrhage. When my blood pressure is going down, then how this system will operate? Are you ready to learn it? It's very easy. If my blood pressure is going down, suppose I develop hemorrhage, my blood pressure is going down, there is less stretch on these nerve endings, less sodium will be entering into these nerve endings, and less frequency of action potentials coming from here. And less action potential reaching to tractus solitarius assume blood pressure is going down. Now it has to elevate the blood pressure. So now it will do the reverse activity. It will inhibit the cardio inhibitory center. So vagal activity will be reduced, and when vagal activity will be reduced, then vagal mediated negative chronotropic action is lost. Heart rate will go up, cardiac output will go up, and blood pressure will go up in the hemorrhage. Secondly, it will stimulate now, this time it is doing opposite. It will stimulate cardio accelerator area. So more sympathetic outflow to the heart neuronally. So there will be increased heart rate, further supporting the blood pressure. Then there will be stimulation of vasomotor center and intense sympathetic overflow all over the body, and that will lead to venoconstriction. Veins stressed volume will be shifted to the other side. Venoconstriction, more venous return, more cardiac filling, more stretch. Frank Starling says more contraction, more stroke volume, more cardiac output, more elevation in blood pressure, right? Then there is arterioloconstriction. When arterioloconstriction occur, right, arterioles constrict, total peripheral resistance goes up, and arterial blood pressure goes up. Meanwhile, there is stimulation to adrenaline centers, right, adrenal medulla. Lot of my blood pressure is going down, I'm suffering with hemorrhage, lot of adrenaline will be released, and this adrenaline will lead to adrenaline mediated venoconstriction, more preload, more venous return, more preload, more cardiac output, more elevation in blood pressure, more support to blood pressure. Plus epinephrine will directly act on S node in positive chronotropic action, act on the AV node, increase conduction, so positive dromotropic action, right, so heart rate will increase. Plus epinephrine will act on the generalized myocardium, increase the contractility, and positive inotropic action. So positive chronotropic action and positive inotropic action of the epinephrine will increase cardiac output. Increased cardiac output will again further support the blood pressure. Of course, epinephrine will also stimulate the smooth muscle zone arterial system, and when arterial system smooth muscle is stimulated, that arterioloconstriction in most of the beds in the body will occur except skeletal muscles. And when most of the arterioles will be constricted, total peripheral resistance will increase. That will be further support to the falling blood pressure, as increased total peripheral resistance stabilizes the or prevent the fall in the diastolic blood pressure. And of course, this epinephrine through the beta 1 receptor will stimulate juxtaglomerular apparatus and more renin-angiotensin-aldosterone axis stimulation, which we'll talk later. Do you have any question about it? Another thing which I would love to mention, that these nerve endings are very sensitive, even though they are sensitive to the absolute rate of blood pressure. But it is the change in the blood pressure which they sense more. This is a change in the blood pressure which these nerve endings sense more. Rather, it is the rate of change in the blood pressure, to which these nerve endings are very, very sensitive. And this is a rapid way to readjust, to prevent the elevation or depression of the blood pressure. So this system tries to stabilize the blood pressure around a set point. Is that right? It does not allow the blood pressure to unduly go very up, or it does not allow the blood pressure to unduly fall down. So it buffers the changes in blood pressure. That is why these two nerves are also called buffer nerves, because they buffer the changes in blood pressure, right? Another point which is worth mentioning at this point is that in some patients with hypertension, right, these nerve endings become adjusted at a high set point. For example, if my mean arterial blood pressure is not 100 but 130, but they adjust with the pressure of 130 and they fire the same frequency of action potential at 130 which they are supposed to fire at 100. So they try to stabilize the blood pressure around 130. So it's in some patients with hypertension, the system is reset at a higher pressure, so it does not help to bring the blood pressure down. Rather, it maintains the blood pressure at a higher level. Is that clear? Then another point which is worth mentioning is that especially these two nerve endings are slightly different in their function. How? That these nerve endings are, you can say, sensitive to increasing blood pressure as well as to decreasing blood pressure, right? But nerve endings on aorta are more sensitive to increasing blood pressure, but if blood pressure decreasing, the rate of firing does not significantly come down. So which are more efficient? Is that right? Carotid sinus. Let's have a break and then we'll continue. Yes. So we were discussing about the neuronal blood regulation and rapid control of the blood pressure. We have already discussed if blood pressure goes down, right? If blood pressure goes down, efferents will fire less. And if efferents will fire less, what will happen? That parasympathetic activity will be less and sympathetic activity will be more. Then if your blood pressure is going up, then what will happen? If your blood pressure is going up, afferent activity will be? No, if blood pressure is going up, afferent activity will be more. If afferent activity is more, it perceives blood pressure is up, so it has to lower down the blood pressure. If it has to bring the blood pressure down, parasympathetic activity has to come down and sympathetic activity has to go up. Is that clear? So these are two parameters which we have discussed, that rise in blood pressure and fall in blood pressure. What happens to afferents? If blood pressure is going up, afferents are going up, and if blood pressure is going down, afferent activity is going down. And parasympathetic nervous system and sympathetic nervous system. Parasympathetic, if blood pressure is going up, parasympathetic will come
No.
down, because you have to slow down the heart, and sympathetic will go up. Is that right? Sympathetic will go up. But when we talk about your blood pressure is dropping, then afferent will report that blood pressure is less action potential going to tractus solitarius. When less action potential going to tractus solitarius, blood pressure is low, so parasympathetic activity will be reduced, and if blood pressure is low, parasympathetic activity will be reduced and sympathetic activity will be increased. I think here we have to correct. If blood pressure is high, afferent activity is more and it has to lower the blood pressure. So if you want to lower the blood pressure, parasympathetic activity has to increase, corrected. Parasympathetic activity has to increase and sympathetic activity has to decrease. Is it clear? You understand how we have manipulated the situation? Then we can come to that if you start, let's suppose, carotid occlusion. If you do carotid occlusion, it means carotid occlusion means, let's suppose we apply a clamp here. We occlude this vessel and no blood going there. No blood going there mean what?
Less pressure.
Of course, less pressure. It means afferent will fire. Yes, what will happen? Afferent will fire with carotid occlusion, they will fire less, and now this system has to elevate the blood pressure. And if this system has to elevate the blood pressure, then parasympathetic has to be decreased and sympathetic has to be more, and heart rate has to be more. Heart rate has to be more. Is that right? Now we come to another situation. Let's suppose there is carotid sinus massage. Carotid sinus massage. Look, if you are massaging it, it means you are increasing the pressure or decreasing the pressure. If you are massaging it, no, look, if you have a pipe and blood, if there's a pipe and there is some water going through that, you start pressing that area and massaging that area, pressure in the lumen will go up or down? Up. So that is what we do, that when we start massaging the carotid sinus, pressure within the sinus become up. So these are understretched or overstretched? When blood pressure is up, actually when you massage here, you are not making the blood pressure up, you are locally manipulating in such a way that as if pressure within, after the massage, pressure in the lumen is increased, and by moving this you are stretching the nerve endings, and locally increased blood pressure also stretches the nerve ending. So nerve endings are stretched more, so afferent activity will become up. Carotid sinus massage, afferent activity will be more. When afferent activity is more, right, afferent activity is more, what will happen to parasympathetic? It will also increase. Is that right? Because it is perceived as if there is high pressure, so it has to slow down the cardiac, and in the same way sympathetic activity has to increase and heart rate has to increase. And actually why we do carotid sinus massage? Because we want that by carotid sinus massage, ninth nerve is taking information to the central nervous system, and from there strong vagal outflow will come, and not only SC node will be inhibited, but if left vagus also fire, AV node will be inhibited. So supraventricular tachycardia are not disturbing the ventricular rhythm. Is that right? When AV node is inhibited, let's suppose if there is atrial flutter or atrial fibrillation, then that fast atrial rhythm cannot go to the ventricle when AV node is inhibited by the superactivity of vagal system, right? Then we can come to, and of course what will happen to blood pressure? What will happen to blood pressure on occlusion and this? If we add a category of blood pressure also here, if you occlude this, the system perceive as if blood pressure is less, so it will elevate the blood pressure. And if you are doing carotid sinus massage, blood pressure should go down, because blood pressure is moving with the sympathetic system. Do you have any question here? If you have any confusion, you can ask me. It's not difficult to understand, right? Then we can talk about that if you cut the afferents, let's suppose you cut down afferents, what will happen? Look, when you cut down the afferents, it means central nervous system receiving no action potential, and reduced action potential is a sign of low blood pressure. So the system will orchestrate to increase blood pressure. System will orchestrate in effort to increase the blood pressure. So when you cut the afferents, if you cut the afferents, no action potential is going on, afferent activity is too much down, rather death of the afferent activity, not the patient. If there is no afferent activity, then it means it perceived as if blood pressure cannot be sensed, it is too low. So naturally parasympathetic activity will be reduced, sympathetic activity will be increased, and blood pressure will be increased, and heart rate will be increased. Is it clear? Or any question about this? So by this diagram, you can easily infer the things, right? Again, first you always remember, what really happened? That when blood pressure is down, afferents fire less. When blood pressure is up, afferent fire more. When you cut down the afferent, it means there is central nervous system wrongly perceive as if there is no blood pressure. So it try to raise the blood pressure. So vagal inhibition will be reduced and cardio acceleration and vasoconstrictor fibers will be working. Am I clear? There is no problem into this. Right? Then we can talk about that from lying down position, if suddenly stand up. If you are lying down and you suddenly stand up, and especially if your blood volume is low, or you have taken some drug which is strongly arteriolodilator. First you understand what happened. Now, from lying down position, suppose this is the patient, right? Person, he suddenly stand up. Then blood tend to gravitate into lower part of the body. The venous return from lower part of the body is reduced because gravity is antagonizing the venous return. So from lying down position, when in the lying down position blood is evenly distributed in the body, you suddenly stand up, the blood tend to pull down. So when blood tend to pull down, then if blood is settling down during sudden standing, venous return is reduced, cardiac output is reduced, blood pressure fall. When blood pressure fall, afferent fires. Afferent increase their fire. Remaining stories you can tell me. That from lying down to standing, suddenly lying down to standing, what will happen? That when you are lying down, suddenly you stand up, blood pool into lower part of the body, venous return is less, cardiac filling is less, cardiac output is less, blood pressure is transiently down. They are transiently under fire or over fire. With blood pressure is down, they will under fire. When they will under fire, this will perceive as if blood pressure is down, so it has to correct the blood pressure. Is that right? It has to elevate the blood pressure. For that purpose, first from lying down position to stand up, blood pool in the lower part of the body, venous return is less, cardiac output is less, blood pressure is less, afferent will fire less. When afferent will fire less, central nervous system will perceive as if there is low blood pressure, so it has to elevate the blood pressure. When it has to elevate the blood pressure, parasympathetic activity should be low, sympathetic activity has to be more, and blood pressure will go up and heart rate will also go up. That is why from lying down position, if you suddenly stand up, this mechanism help you to maintain the blood flow. Because when from lying down position, when you suddenly stand up, there is a sudden fall in the blood pressure which triggers the afferent system, which triggers the central nervous system to bring more sympathetic outflow, and there should be venoconstriction. There should be venoconstriction, and so that venous return should be maintained. Now you imagine, if a person has very low blood volume in the body, he is dehydrated. This is a very important point. Rahul, please. First you understand normal, then we go into detail. What we are talking about, let's suppose here you are. Look here. Here you are lying down. First we'll talk about when you're perfectly healthy. Suddenly you stand up, blood gravitate down. Cardiac output become less. Afferent system fire to the CNS. CNS bring more sympathetic outflow so that veins in the body should constrict and don't allow the blood to gravitate, so that venous return to heart should be maintained, right? And slight tachycardia will be also produced, venoconstriction will be also produced, and cardiac output will be well maintained. Now you imagine that you had a world-class diarrhea, perfect diarrhea, cholera. You are severely dehydrated, and someone asked you suddenly stand up. You are a patient with diarrhea, you have lost a lot of fluid, your fluids have not been replaced, your blood volume is less. If someone asks you suddenly to stand up, you will feel blackout and vertigo. Why? Let me explain. When you suddenly stand up, right, venous return will be less and cardiac output will be less. Listen carefully. Afferent system will report to the CNS blood pressure is less. CNS will give sympathetic outflow. Veins will constrict to some extent, or maybe due to diarrhea because there was low blood pressure, already sympathetic flow was there. Now listen carefully. Vein will constrict, but because your volume is very less due to diarrhea, do you think constricted vein can squeeze enough venous return? Can they squeeze? If you have very low blood volume, even though on standing sympathetic system fire, can sympathetic system can constrict, even though it will constrict the vein? Do you think if there's low volume of blood available in the body, can veins in spite of sympathetic mediated constriction, can vein squeeze enough and maintain enough cardiac venous return? No, and still your cardiac output will be less. And that is why when you stand up and your cardiac output will be remaining less, not corrected, you will find vertigo, a sign of hypoperfusion to central nervous system, right? With that, if there's too low blood pressure, cerebral flow, their cerebral metabolism goes down. Cerebral cortex metabolism go down and you become transiently unconscious or you feel blackout. Is that clear? Secondly, in this person, attention, Rahul, if you have severe loss of fluid, first you have to stand again normal, and this time we'll take the blood pressure. You are lying down, suppose your blood pressure is 120/80, we are just supposing. You suddenly stand up, and if you are healthy, right, afferent venous return reduced, afferent system fires, sympathetic outflow, is that right? And blood pressure should slightly go up. So from lying down position to stand up, either there should not be a significant fall in blood pressure, or in a healthy person you may even expect blood pressure to shoot a little up. But if you are a person who has severe what? Volume depletion. You have severe volume depletion. Volume of the blood is very, very less. If volume of the blood is very less and you suddenly stand up, do you think, even though afferent will inform the central nervous system that blood pressure is low, central nervous system will give sympathetic outflow, constriction of the vein will be there, is that right? But still, what happens? You cannot maintain the venous return, cardiac output drop, and on standing when you take blood pressure, rather than going up, blood pressure will go down. So on lying down, your blood pressure was suppose 120/80. On standing, if it becomes 90/60, this is called orthostatic hypotension. What is orthostatic hypotension? First, understand the basic, then understand the pathology. What is the basic? In a normal person, when from lying down position he suddenly stand up, right? Venous return is reduced, cardiac output is reduced, central nervous system is informed that blood pressure is less, sympathetic outflow will be there, and in a normal person, veins will constrict to maintain the venous return. So in normal person, systolic blood pressure does not have any significant drop on standing suddenly. But a person who is volume depleted, or a person who is having sympatholytic drug, for example, if I'm a person, either I'm volume depleted, I'm having less volume, or I'm having strong toxicity of arteriolodilator or venodilator drugs, or I'm having sympathetic blocker, receptor blocker, or ganglion blocker, or due to any reason my sympathetic system is not working, right? So I have sympatholytic activity in my body. Now, such person who has reduced sympathetic activity in the body or blocked sympathetic activity of body, this person from lying down position, if he suddenly stand up, blood will gravitate. Central nervous system will try to fire the sympathetic system. But if sympathetic system is blocked, if ganglions are blocked, or now winding those of sympathetic nervous system are blocked, or alpha-1 receptors are blocked, or arterioles are very much direct vasodilator like hydralazines are there, or volume is less. Under all these circumstances, can you squeeze the blood? No. So from lying down to standing, blood will fall, significant fall in systolic blood pressure, more than 10 millimeter of mercury. We will say this person has orthostatic hypotension. And these people, when they suddenly from lying down position to stand up, usually they develop vertigo and blackouts. Am I clear to you? Right? That is why it's very important information that if someone, you have given someone some antihypertensive drug, especially the drug which blocks the alpha-1 receptor, right? Or you have given a patient first time sympatholytic drug, right? You have to take care of the patient. That ask the patient that once he has taken the drug first time, it's better patient to take some rest, right? So their body should adjust, right? Or because if for example, he has taken first time antihypertensive drug and body respond well to the drug, and if body respond really too well, vessels are too much dilated, or sympathetic nervous system is not working well, you have impaired the sympathetic nervous system by antihypertensive drugs. This person, whenever from lying down position will stand up, he will be very angry with you. He will say, what a funny doctor you are. You give me a drug and I develop vertigo or I develop blackouts. It means your drug is underworking or overworking. Overworking, you have to reduce the dose. Is that right? Am I clear to you? Right? Then one more thing, that let's suppose if we produce volume load in the body, what will happen to these parameters? Volume load in the body mean, for example, you give 2 liters of normal saline to normal person. If you give volume load to the person, then venous return will, first of all, blood volume will increase. If blood volume increases, then venous return increases. If venous return increases, then cardiac output increases, and it means blood pressure increases. It means the afferent will fire more, and CNS has to bring the blood pressure down. And if CNS has to bring the blood pressure down, it will increase the parasympathetic activity, right, and decrease the sympathetic activity. Is that right? So if you volume overload a person, what will happen to the person? Listen, first of all, we start from here, that if you volume overload a person, volume load, if you have produced volume load over there, now you can imagine blood pressure is going up, right? So afferent activity will go up, then parasympathetic activity has to come down. If blood pressure is going up, parasympathetic, listen, blood pressure is going up, it's firing more, so it has to inhibit the heart, so parasympathetic activity has to be up, and blood pressure, we want to bring the blood pressure down, so sympathetic activity will be less, eventually blood pressure will be less, and heart rate will be less. Is it clear? Or any problem about this? Now, the long-term regulation of the blood pressure is dependent on Renin-Angiotensin-Aldosterone axis or Renin-Angiotensin-Aldosterone system. It regulates the blood pressure by handling the blood volume and body sodium concentration. Now, let's see how it works, right? And what are the major players in this system? Let's suppose here is again your cardiovascular system. Okay, let's make the right heart and left heart separately. Here is your right heart, and here is your lung, a very important player in Renin-Angiotensin-Aldosterone axis. And blood through the lungs is going to the left heart, and from the left heart, blood is going to the general systemic circulation. Now, it's a very, very simple diagram, right, of cardiovascular system, and we have to see the how system works. Now listen carefully. In Renin-Angiotensin-Aldosterone system, kidneys play the very important role. It's a very, very big role of the kidney. So let me draw one kidney here, right? And let's suppose here is a nephron. And of course every kidney has about 1 million nephrons, but here I draw only one nephron. Let's suppose here is arterial blood to the kidney, arterial blood flow going to the kidney, and from here this is the venous return from the kidney. Right? And then another important player is your liver. Right? Okay, I will draw the liver here. Now we'll see how the system really works. Let's suppose we start from here that someone has hemorrhage and his bleeding is going on. So there's drop in blood pressure. There's drop in blood pressure, of course, and within second it will activate the neurological mechanism, right? Which we will not discuss now. We have discussed in previous lecture. Of course, here we'll see that when blood pressure is dropped, so naturally the perfusion to many organs will reduce, including the renal system. So a very important finding is, as the blood pressure is going down, there is reduced renal perfusion. There is reduced renal perfusion. Blood flow to kidney is reduced. Now, when blood flow in the kidney is reduced, it will trigger some mechanism. One mechanism is that, let's suppose this is afferent arteriole and this is arteriole. The smooth muscle of afferent arteriole, as soon as afferent arteriole is coming near to the glomerulus, the smooth muscles of afferent arteriole undergo a special type of change, right? And exactly around this point, nephron loops back and a portion of a nephron, right? This is called macula densa, right? This portion is at the very beginning of distal convoluted tubule. This proximal convoluted tubule, loop of Henle, thick ascending limb, and distal convoluted tubule. At the beginning of the distal convoluted tubule, right, there is an area, and this area which I am showing is called macula densa. And afferent arteriolar modified smooth muscle group, this is called Polke-Sen. What it is called? Polke. The smooth muscles as a group, this and this together are called Polke-Sen. And these are Polke-Sen cells, which are basically modified smooth muscles of afferent arteriole. And remember, these cells are going to work as baroreceptor, right? They are going to act as baroreceptor. And macula densa are the cells which belong to the nephron, right? And they are going to act as chemoreceptors. And this Polke-Sen system and macula densa, they are held together with some connective tissue cells which are called Lassus cells. These green cells are Lassus cell, LA, Lassus cells. They are connective tissue cells. And all this structure, that is Polke-Sen, Lassus cells and macula densa, all that structure as a group, this structure as a group, right, this whole structure is called JuxtaGlomerular Apparatus. What is this structure? We have to focus this. This structure is called JuxtaGlomerular Apparatus, because this whole apparatus is a very specialized apparatus made of cells which is very near to the glomerulus. That is why this whole apparatus is called JuxtaGlomerular Apparatus. So in the JuxtaGlomerular Apparatus, there are contribution from the afferent arteriole and there is contribution by the distal convoluted tubule. Is that right? From afferent arteriole, there is Polke-Sen cells, special modified smooth muscles. From the macula densa, from the nephron, the macula densa cells, which are very macula densa cells are very, very sensitive to the sodium. So we call them sodium sensors, or we simply call them chemo sensors, right? And Polke-Sen act as a baro sensor. And there are some connective tissue cells holding this structure together. Now, this is a very specialized structure, and it is present with every glomerulus. And if one kidney has 1 million glomeruli, then it means in each kidney you have about 1 million juxtaglomerular apparatuses. Now, these very fine apparatuses, what is their function? Actually, they have to adjust the blood pressure according to the perfusion pattern here, and they have to adjust the blood pressure according to what is the sodium coming here. Let me explain exactly how it happened. Let's go back to our discussion. I was saying a person is bleeding, his blood pressure is falling. If a person's blood pressure is falling, naturally renal perfusion is decreased. blood flow to kidney is decreased. When blood flow to kidney is decreased, then afferent arterioles will be less stretched. They will be less stretched. And if blood pressure increases, then they will be more stretched. But in case of hypotension, they will be less stretched. Now, these cells are very, very sensitive to the stretch, and through that stretch, they determine what is the blood pressure. So when blood pressure is going down, this apparatus is less stretched, and reduced stretch, right, or reduced blood pressure activates this apparatus. And what really happens that this apparatus start releasing a very special type of enzyme in blood, and this enzyme is released JuxtaGlomerular apparatus when the afferent arterioles sense that blood pressure is low. Right, this enzyme is through the renal vein go back to the where? Yeah, to the venous circulation. Right, so this is that enzyme. And what is this enzyme called? Renin. What is it? Renin. So actually, what is happening that when blood pressure is reduced, renal perfusion is less, right? Afferent arterioles are less stretched, then baroreceptor in the juxtaglomerular apparatus sense low blood pressure and they release renin into systemic circulation. This is one thing. Second thing is that when renal perfusion is less, then naturally the glomerular filtration pressures are less. And when filtration pressure in the glomeruli are less, it means that filtration has been reduced. And if there is less filtration, then naturally, as you can say, luminal fluid is moving through the nephron, this fluid is moving fastly or slowly? You have to slowly. It's very easy to understand. When blood pressure is less, then renal perfusion is less. Number one, reduced renal perfusion was sensed by the baroreceptor apparatus of the juxtaglomerular apparatus, and this baroreceptor system forced the release of renin. Secondly, due to low renal blood flow, glomerular filtration rate of GFR is less. When glomerular filtration is less, then luminal fluid is less. So luminal fluid is moving very, very slowly through the nephron. When luminal, look now, when luminal fluid is moving through the nephron very, very slowly, the nephron cells have more chance, tubular cells have more chance to work on this fluid. And these cells will retain excessive amount of sodium. As it is normally about 65% of the sodium is reabsorbed by proximal convoluted tubule, right? And 25% is reabsorbed from here. So about 10% sodium normally reaches here. But here, because luminal fluid is moving very slowly, so these cells can work more efficiently on the less fluid and they reabsorb sodium very effectively. So and of course sodium is reabsorbed from this area also. So by the time sodium reaches here, it is less than normal. There is low sodium delivered to the macula densa. And macula densa, which is a part of the juxtaglomerular apparatus, is very, very sensitive to the sodium loading, right? Again, let me repeat. Blood pressure was less, renal perfusion was less, GFR was less, luminal fluid was less, and luminal fluid was moving very slowly, so cells of the nephron could work on less fluid more efficiently, so they removed the sodium in more efficient fashion, so very little sodium reaches to the onset of distal convoluted tubule where macula densa is there. Macula densa is very sensitive to reduced sodium. When there is less sodium delivered here, macula densa will stimulate the structures of juxtaglomerular apparatus, and juxtaglomerular apparatus under the stimulation of macula densa will release what? More renin. More renin. So it means renin is released by juxtaglomerular apparatus under two influences. One influence is the renin is released because blood pressure is less and baroreceptors are activated. What are baroreceptors? Modified smooth muscles of afferent arteriole. Number two, renin is released because there is a reduced GFR and you can say nephron is reabsorbing the sodium more efficiently, so very little sodium is delivered to the macula densa, and macula densa loves sodium. Until it is getting good amount of sodium, it remains sleeping. As soon as no more fluid is very less salty, it loves the salt. If there is less salt, if there is less sodium coming here, macula densa will wake up and activate the JuxtaGlomerular apparatus. So more renin is released. So falling blood pressure releases renin here. One more thing which I would love to mention here, that JuxtaGlomerular apparatus has beta 1 adrenergic receptors. So you already know falling blood pressure activates the sympathetic outflow from CNS, and falling blood pressure also through the baroreceptor system also not only release more sympathetic activity, rather also releases more epinephrine from the adrenal medulla. So epinephrine and norepinephrine work on the juxtaglomerular apparatus under the influence of sympathetic stimulation and through the beta 1 receptor, beta 1 adrenergic receptor. So sympathetic stimulation itself directly stimulates the juxtaglomerular apparatus so that there is further release of renin. How many things are right now? My blood pressure is falling, low blood pressure in the renal system, baroreceptor activated, release renin. Reduce GFR, reduce sodium loading to the macula densa, again release renin. Due to my low blood pressure, baroreceptors have fired, they have reduced their firing. Tractus solitarius, which is the master regulator of the vasomotor center within the medulla, tractus solitarius activate the vasomotor center and sympathetic outflow. Sympathetic outflow has many functions. One of the function is that sympathetic outflow also stimulates the juxtaglomerular apparatus, further release of renin. Now this renin, when it comes to blood, what really happens? Now let's talk about this renin. That once this renin is coming to the general circulation, what this renin is going to do? Let me write here. This is the renin which is right. Now blood levels of the renin will increase. Renin is an enzyme. What it will do? Actually, in the blood already there is a special protein present, and this protein is released by hepatocytes. Hepatocytes synthesize many protein. One of the protein which is synthesized by hepatocytes, that protein is called angiotensin-Conversion-Enzyme, angiotensinogen. Angiotensinogen is an inactive protein. It is an inactive protein which is released by the liver, and right now it must be present in your circulation. As soon as renin come, this is the point to understand, as soon as renin come, it will work on angiotensinogen and convert the angiotensinogen into angiotensin 1. So what is the function of renin? That renin could act on the angiotensinogen which was already present in the blood and convert the angiotensinogen into angiotensin 1. Angiotensin 1. Angiotensin 1 is decapeptide because it has 10 amino acids. Now, angiotensin 1, right, what it will do? Angiotensin 1. Angiotensin 1 will pass through the right heart and it will pass through the pulmonary circulation. Now this point is very important to understand. What is arriving here? Angiotensin 1. This is angiotensin 1. Now in the lungs, in the pulmonary circulation, these are the capillary cells over there, right? Actually this is supposed microcirculation of pulmonary system, right? Here there are endothelial cells. These are endothelial cells. These endothelial cells on pulmonary capillary, they are loaded with special type of enzyme. They are having a very special type of enzyme, expressed on their surface. So we can say a unique type of enzyme is synthesized and expressed on the surface of endothelial cells in pulmonary microcirculation. So when this angiotensin 1 is passing through this, these enzymes will work on angiotensin 1 and remove 2 amino acids from there. Angiotensin 1 was having how many amino acids? 10. So when it will come out of lungs, it is converted into angiotensin 2, which has 8 amino acids. That is why it is called octapeptide. Originally it was decapeptide, and now it is converted into octapeptide, angiotensin 2. So again, listen carefully. What really happens that within the pulmonary circulation, the endothelial lining is expressing unique type of enzymes which are able to convert angiotensin 1 into angiotensin 2. And you have to remember, angiotensin 1 is inactive, and these enzymes by removing 2 amino acids and converting angiotensin 1 into angiotensin 2 are actually activating this, because angiotensin 2 is an active product, right? And this enzyme is called, what is the name of this enzyme? This enzyme is called angiotensin converting enzyme. So don't tell anyone that angiotensin converting enzyme is present in lung. Everyone knows it is present in lung. You have to be very clear. It is present in on the endothelial cells lining the microcirculation of pulmonary system. Is that right? So as now again blood pressure is dropping, JuxtaGlomerular apparatus is releasing renin, rising levels of renin are converting more and more angiotensinogen into angiotensin 1. As angiotensin 1 is passing through the pulmonary circulation, angiotensin 1 is acted upon by angiotensin converting enzyme, and they are converting angiotensin 1 into angiotensin 2. Angiotensin 2 is the real active thing. Now, what will happen to this angiotensin 2? Angiotensin 2 through the systemic circulation will reach to the systemic circulation. Now we have to see what are the functions of angiotensin 2. Now we have to talk about that patient who has low blood pressure, right? In his blood there is a high level of angiotensin 2. Now we have to see what is the function of angiotensin 2. Listen, it has many functions, angiotensin 2. Number 1, angiotensin 2 have receptors on the blood vessels. Is that right? Angiotensin 2 have receptors on the blood vessels. For example, they act as they have receptors on the blood vessels, and let's suppose if this is a smooth muscle of a blood vessel, here is angiotensin 2 receptor. These are what type of receptor? 7-pass receptor. This is angiotensin 2. So angiotensin 2, when it binds with its receptor, the 7-pass receptor which is inside coupled with GQ, and GQ can stimulate phospholipase C, and you must be knowing that phospholipase C can break down phosphatidyl inositol diphosphate lipids present in the cell membrane, and they will break down into IP3 and diacyl glycerol. IP3 will act on endoplasmic reticulum, right? And when IP3 act on endoplasmic reticulum releases calcium. This intracellular calcium level. So we can say angiotensin 2 through its receptor and intracellular signaling pathway increase calcium level in the target cell. Now this calcium level, when it increases in venous smooth muscle, veins will constrict. When calcium level will increase in arteriolar smooth muscle, then arterioles will constrict. So it will act as a powerful vasoconstrictor. Now this will lead to venoconstriction and arterioloconstriction. Venoconstriction and arterioloconstriction. Is that right? When veins will constrict, you know what will happen? the blood volume which is present in veins, when veins will constrict, they will increase the venous return to the heart. Venoconstriction will lead to, yes, increased venous return to heart. For example, if I say this was the smooth muscle on the vein, when this smooth muscle will contract, venous return to heart is increased, and what will happen? That will lead to increased, yes, you will tell me, that will lead to increased end diastolic volume. That will lead to increased, yes, you must be knowing, when heart is filled more, when veins will constrict, more blood is returning to the heart. When heart is filled more, according to Frank-Starling law, more you end diastolic volume, more preload, more stretch in the myocardium, more myocardium will contract, and there will be more stroke volume. And increased stroke volume will translate into increased, yes, cardiac output. And when cardiac output increases, your systolic blood pressure goes up. That will lead to increase in systolic blood pressure. So this is one mechanism what angiotensin 2 has done. Now we'll see the second wing. In second wing, it is producing arterioloconstriction. What it is producing? Arterioloconstriction. When angiotensin 2 produces arterioloconstriction, right, what will happen? That will lead to, yes, that will lead to increase total peripheral resistance. You know, when arterioles will constrict, right, when arterioles will constrict, because arterioles are smooth muscles that are loaded with lot of angiotensin 2 receptors. When arterioles will constrict, right, then it is difficult for the blood to move from arterial side to venous side. And when blood is trapped on the arterial side, what happens? Diastolic blood pressure goes up. So that will lead to increase in diastolic blood pressure. So you see what was happening? Blood pressure was going down, and Renin-Angiotensin system has been activated. We did not talk about aldosterone yet. And angiotensin 2 can produce venoconstriction and take the and increase the cardiac output and take the systolic blood pressure up. And angiotensin 2 can produce arterioloconstriction, increase the total peripheral resistance, and take the diastolic blood pressure up. Is it clear? Now one more thing, that angiotensin 2 can also act on, it has receptors on central nervous system. Angiotensin 2 has receptors on central nervous system. These receptors are on hypothalamus. So angiotensin 2 will act not only as a vasoconstrictor, but angiotensin 2 will act on the central nervous system, right? And in the central nervous system, it acts on certain neurons which are under the subfornical area. We call that, in the hypothalamus, there are some neurons, and those group of neurons act as a thirst center. They act as a thirst center. So when angiotensin 2 reaches here, right, then sense of thirst is produced, and if patient is not in coma, a person who is having bleeding is oriented, he will ask for water or he will complain about thirst. Is that right? So that is another attempt, that if you provide this person more and more water, he will drink, so that his blood volume should go up. When blood volume should go up, venous return should go up, cardiac venous return will be increased, and diastolic volume will be increased, stroke volume will be increased, cardiac output will be increased, and systolic blood pressure will be increased. So we have seen two things, that by acting on the central nervous system, it will increase thirst. It will increase thirst. And it has also produced vasoconstriction, right, veno and arterioloconstriction. Then it has to do one more function, which is very important to understand. You know that from the CNS, let's suppose I draw the CNS here, and from here is the preganglionic sympathetic fibers, and from here, from the ganglion, these are postganglionic sympathetic fibers. You know, postganglionic sympathetic fibers release norepinephrine. Now, actually, you will be surprised to know that all the sympathetic nerve endings have angiotensin II receptor. Which receptor? Angiotensin II receptor. And when angiotensin II act on sympathetic nerve endings, they are stimulated and they release excessive amount of, yes, they release excessive amount of norepinephrine. So it means that angiotensin II can act on the sympathetic nerve endings and they become more active and they release excessive amount of norepinephrine, and this norepinephrine will act as cardiostimulant, increase cardiac output, stabilize the blood pressure. This norepinephrine will act as venoconstrictor as well as arterioloconstrictor. It means angiotensin II not only directly stimulates the venoconstriction and arterioloconstriction, it enhances the sympathetic response in the body as well. Am I clear? Then another important function of angiotensin II is that it will act on the, yes, it will act on adrenal gland, right? It has receptors on the adrenal gland cortical area. Let me draw the adrenal gland, right? Let's suppose this is adrenal medulla, right? And here is adrenal gland cortex. Actually, this is zona glomerulosa and this is zona fasciculata and this is zona reticularis. It is just like a plant, flowery plant. These are the roots, these are the stem, these are the flowers, right? So these are three layers. Zona glomerulosa, here it is. Zona glomerulosa is mainly producing aldosterone. Zona fasciculata, that is concerned with synthesis of glucocorticoid, and zona reticularis is mainly concerned with the androgens production. Now, right now we'll concentrate on zona glomerulosa. Actually, cells on the zona glomerulosa have also receptors for angiotensin II. So angiotensin II is able to stimulate the receptors on zona glomerulosa. When zona glomerulosa is stimulated, right, under the influence of angiotensin II, these cells release a hormone called aldosterone. The cells release a hormone aldosterone. Now, it means as angiotensin I is converting into angiotensin II, right, more and more aldosterone will be released from zona glomerulosa. Now, what this aldosterone will be doing? This aldosterone will come into general circulation and eventually through renal flow, this aldosterone will reach to the kidney. Now, aldosterone is steroid hormone. It is lipid soluble. It will well distribute all over the body. This aldosterone will well distribute all over the body, including the renal tissue. Now, how it will work in the kidney? We have to see how the aldosterone work on the kidney. Aldosterone work on special cells in the distal convoluted tubule and collecting tubules. These cells are called principal cells. These are called principal cells. Now we have to see how these cells work under the directions of aldosterone. Now I'm going to draw one of this cell. This cell I'm going to draw there. This was the nephron and here is that cell. Now how this cell is going to work? I've removed a piece from here and here and put it over there to explain. Now how when aldosterone work on this cell, everyone knows that when aldosterone work on the renal system, it retains salt and water. But we have to see exactly how it is retaining. Look here. Actually, aldosterone, suppose this is aldosterone. aldosterone will diffuse into these cells and it will bind with its unique receptors. This was the receptor of aldosterone. When aldosterone binds with its intracellular receptor, this receptor acts as a transcription factor. It stimulates certain genes. Let's suppose here is the nucleus and this is genetic program and there are different genes. These are three genes which I have showed in this diagram, right? Now, when gene number 1 is, the top gene is activated, this will synthesize sodium channels. When lower gene is activated, it will synthesize potassium channels. When middle gene is activated, it will produce a lot of, what is this? Sodium potassium ATPases. Okay, let me redesign this for easy understanding. That there are three genes here, right? The gene number 1, okay, I've rearranged the component. Gene number 1, the top gene is for sodium potassium ATPases. Gene number 2 is for sodium channels. Gene number 3 is for potassium channels. Now, this transcription factor will stimulate all these genes. So what aldosterone does? Aldosterone came into principal cells of the nephron, bound with its receptor, and aldosterone with its receptor complex transfer to the nucleus and activate certain genes. Now we'll see what is the effect. Gene number 1 which is activated, that lead to formation of such messenger RNA that messenger RNA translate into proteins which are actually sodium potassium ATPases. So cell will synthesize more sodium potassium ATPases, and these sodium potassium ATPases will be planted on the basolateral membrane of this cell. So what really happens, after the influence of aldosterone, the sodium potassium ATPase concentration on the basolateral membrane is increased. When sodium potassium ATPase concentration on basolateral membrane is increased, these sodium potassium ATPases start working more. So what these sodium potassium ATPases are doing? These are constantly throwing the sodium out of the cell, right? So sodium potassium ATPases keep on throwing the sodium, they keep on using the ATP and keep on throwing the sodium out of the cell. So we can say under the influence of these pumps, this cell start throwing the sodium outside from the cell to interstitium, right? So this sodium which is coming here, it will be going back to the circulatory system. Is that right? Number 1. Number 2, gene number 2 is activated and that produces a lot of proteins which act as sodium channels, and these channels are added. The product of the second gene which produce the sodium channels, these channels are planted on the luminal side of the nephron. And third is the gene which is activated and this synthesizes the potassium channels. So it means gene number 1 will increase sodium potassium ATPases on basolateral membrane, and activation of gene number 2 and 3 will increase the sodium channels and potassium channels on the luminal side. Now you see, what will be the end result? Due to these all alteration, the basolateral membrane of this principal cell will start throwing lot of sodium from the cell to interstitium, and this sodium will go back to the body. And cell will become now very, very sodium poor. Cell will become very much sodium poor because cell is throwing the sodium to the blood. Now, when cell will become poor in sodium, naturally any sodium which was going from here to be lost into urine, because cell is very poor in sodium and membrane has lot of sodium channels, so membrane is very permeable to sodium. So from the nephron lumen, sodium will start shifting to the cell. So as more and more sodium from the nephron lumen is shifting to the cell, the sodium potassium ATPases are throwing this sodium from the cell to the blood. In this way, in this nephron, if there was some sodium to be lost into urine, actually that sodium will be taken up by these cells. And from the luminal side, sodium is taken up by the sodium channels. And once sodium is inside the cell, sodium potassium ATPases throw the sodium out of the cell. But there is one problem related with it. The sodium potassium ATPases, as they are throwing the sodium from the principal cell to the blood side, interstitium, they are also taking the potassium and taking from the blood side and throwing it to the cell. So this cell, so we can say sodium potassium ATPases are taking the potassium from the blood and throwing it into principal cells. So cell is getting rich in, yes, rich in potassium. And when cell become very rich in potassium, potassium move from the cell, from the luminal side through its, you can say, channels to the nephron lumen, right? In this way, by the action of aldosterone, principal cells are modified in such a way they reabsorb sodium, and whenever they reabsorb sodium, some water follow. So they reabsorb salt and water at the cost of throwing more potassium into urine. Is that right? So we can say that under the influence of aldosterone, what really happens that principal cell reabsorb salt and water and waste the potassium into urine. The salt and water which comes back to the body, this salt and water which comes back to the body, this will add to the blood volume. And when there is more blood volume, now what has happened? Renin-Angiotensin-Aldosterone axis has been fully operated and aldosterone has acted upon principal cells. And remember, action of renin-angiotensin-aldosterone axis takes long time, not like neuronal mechanism. It takes to be fully operative hours to days. And when it is fully operative, then principal cells are modified, that the basolateral membrane become rich in sodium potassium ATPases and their luminal membranes become rich in sodium and potassium channels, right? And sodium potassium ATPases keep on throwing the sodium from the cell to the blood, right? So cell become poor in sodium, so it starts sucking the sodium from nephron lumen to the cell and throwing actively sodium to the blood, and water follows, salt and water retention. But sodium potassium ATPases take the potassium from the interstitial side or blood side and throw into cell become rich in potassium, and meanwhile there are a lot of potassium channels are synthesized and planted on the luminal side, so potassium will start leaking. Is that right? So in this way salt and water will be retained, so in the urine sodium will be less, water will be less, and in the urine potassium will be more. Is that right? And remaining story, you know, when salt and water is retained, what happens? Blood volume increases. When blood volume increases, venous return increases. When venous return to the heart increases, end-diastolic volume increases, preload increases, stretch on myocardium increases, myocardium more strongly contract, and stroke volume increases, cardiac output increases, right? Systolic blood pressure is stabilized, is elevated. Am I clear? Story is not yet finite. Actually, now they have discovered that these cells, what are these cells? Proximal convoluted tubular cells. They are also very rich in aldosterone, they are very rich in angiotensin II receptor. I will draw one cell, this over here, on the proximal convoluted tubule. This is the luminal side and it is basolateral side. Actually, there are angiotensin II receptors present over here also, right? And when angiotensin II work here, angiotensin II, when it work and stimulate these cells, what really happens? That these cells start, there is a special transporter here, and these cells start taking up more sodium from the lumen to the cell, and this sodium through the sodium potassium ATPases will again go to the blood, because and whenever it takes some sodium in, you know, filtered sodium is coming in, so these cells under the stimulation of angiotensin II, these cells start taking up extra amount of sodium. Normally they take a lot of sodium, but under this influence they will take extra amount of sodium reabsorption. But every time they take more sodium, they secrete some protons. So it means that angiotensin II here stimulate sodium proton counter transporter, right? That these cells on the luminal side, they are having sodium proton counter transport. So when angiotensin 2 stimulates this transporter, these cells start taking more sodium from the lumen to the cell to the blood, and from the cell they start throwing out more. From the cell they start throwing out more proton. This is suppose lumen. And what really happens? There was some sodium and bicarbonate. There was sodium with some bicarbonate coming from the filtration, bicarbonate. Now what really happened? This bicarbonate will bind with the proton, and proton or bicarbonate together will convert into H2CO3, which will break down into, yes, carbon dioxide and water. This carbon dioxide will go into cell, and this will fuse with the water of the cell and break down into, first it will convert into H2CO3, and then it will break down into proton and bicarb, and this bicarb will go to the blood. If you don't understand, I should make a larger diagram. What do you think? Should I make a larger diagram? That is exactly what is happening here. Okay, I will remove this diagram so explain exactly what happens there. I'm going to show you now how a proximal convoluted tubular cell work under the influence of, now this was the filtration system, this is a lumen, this is proximal convoluted tubular cell. Angiotensin 2 stimulate the receptors of the cell, and this give intracellular signaling, and this activate a special type of transporter. When angiotensin 2 stimulates this transporter, more sodium is going to the cell from the lumen. So capacity of filtered sodium to be reabsorbed by proximal tubule is increased, and this sodium will be added to the blood. At the same time, whenever more sodium is taken up by the cell, a more proton is thrown into lumen. Now this proton, because it is sodium proton counter transporter which is activated, now this proton will bind with the filtered bicarbonate, and when proton and bicarbonate will fuse together, they will convert H2CO3, carbonic acid, which will break down into carbon dioxide and water. And this phenomenon occur under the influence of an enzyme, which is this enzyme. And what is the name of this enzyme which is helping in all this pathway? There is a special name of this enzyme, carbonic anhydrase, and because this is on the luminal side, we call it luminal carbonic anhydrase. And this carbon dioxide will come into cell. This will fuse with the cellular water and convert into carbonic acid, H2CO3, and this will break down into proton will be recycled and bicarbonate will be generated. H2CO3 will break down into proton and HCO3, bicarbonate, and this bicarbonate will go to the blood from the basal side, and already the sodium which was taken up, that will also come to the blood. So we say that angiotensin 2 by stimulating the system has increased the reabsorption of sodium and bicarbonate from the proximal convoluted tubule. Is that right? Of course that helps in the volume of the blood, right? Again, in the cell also there is similar enzyme present within the cell, and this enzyme is called cellular or cytoplasmic carbonic anhydrase. So in the proximal convoluted tubule, what really happens that under the influence of angiotensin 2, sodium proton counter transporters are activated, and more sodium is reabsorbed, more protons are thrown to the lumen. These protons react with bicarbonate, make carbonic acid, which dissociate into carbon dioxide and water. And in this way, this bicarbonate disappears, but carbon dioxide goes into cell, and by fusing with the water, converting into carbonic acid and releasing bicarbonate and proton, this bicarbonate has disappeared, but here new bicarbonate has been generated, which is thrown to the blood. So in this way, sodium angiotensin 2 act on the proximal convoluted tubular cell to enhance the sodium and bicarbonate reabsorption. Is it clear? Now, angiotensin 2 has how many functions up to now? It has one very important function still. Actually, angiotensin 2 receptors are present on the efferent arteriolar smooth muscle in very high concentration. Angiotensin 2 receptors are present on efferent arteriolar smooth muscle in very high concentration. So once angiotensin 2 is produced, it will act in this area, and when it will act on this, there will be intense efferent arteriolar constriction, right? And what is the advantage of this constriction? Because already blood pressure was less, so GFR was dropping. By constricting the efferent arteriole, glomerular filtration is maintained, so that renal function should not be too much disturbed. Is that right? Any question you have about the system? We will just talk now that which are the drugs which act on this system, because this system is very, very important. I will talk just about few drugs, right? Now, let's talk about few drugs which act on this system. The first very important group of drug is angiotensin-converting-enzyme inhibitor. This drug basically work on these enzymes and inhibits them. These drugs are like captopril. You must be knowing the name of them. Captopril, yes, enalapril, lisinopril, and there are many drugs of this group. So these captopril-like drugs, they work on in the lung, on the pulmonary circulation, on the endothelial lining of the pulmonary circulation, because this endothelial lining is expressing angiotensin converting enzymes. So these enzymes are inhibited by captopril. So angiotensin 1 cannot be converted into angiotensin 2. When angiotensin 1 cannot be converted into angiotensin 2, then these drugs basically reduce the level of angiotensin 2 in the body. Naturally, when angiotensin 2 is less, veins will dilate, right? Because angiotensin 2 mediated venoconstriction is not maintained. When veins will dilate, then what will happen? That venous pooling will occur, and there will less venous return to the heart, less cardiac output, and blood pressure will drop, because these drugs are very commonly used as antihypertensives. Secondly, angiotensin 2 mediated arterioloconstriction is also lost, and arterioles dilate. When arterioles dilate, total peripheral resistance reduces and diastolic blood pressure goes down. Thirdly, when angiotensin 2 is less, right, then this part of the nephron, proximal convoluted tubule, are not retaining sodium and bicarbonate additionally. So loss of sodium and bicarb also help us to get rid of extra volume and reduce the blood volume and correct the elevated blood pressure. Then most important thing, when angiotensin 2 is less, right, then it cannot stimulate the zona glomerulosa to release aldosterone. So blood level of aldosterone also become less. When aldosterone is less, of course then aldosterone cannot work on principal cells. And if there is less aldosterone action on the principal cell, then principal cell do not have enough sodium potassium ATPases on basolateral membrane, and principal cells do not have enough sodium and potassium channels on the luminal membrane. So principal cell have reduced capacity to retain salt and water and reduced capacity to throw the potassium. So this patient, because it cannot retain salt and water, right, he will lose the salt and water into urine, and blood volume will become less, venous return will become less, of course cardiac filling will become less, and cardiac output will be less, and systolic blood pressure will come down. But one important thing is that when you are giving this drug, when angiotensin 2 become less, aldosterone become less, then these cells cannot throw the potassium from the body to urine. So there is a risk of hyperkalemia. What is the risk? There is the risk of hyperkalemia with these drugs. So this is one way how angiotensin converting enzymes, captopril, work. But now there is a very important clinical statement. They say never give angiotensin converting enzyme inhibitors to a patient who has renal artery stenosis. Let me explain why it is contraindicated there, why it should not be given. Let us suppose that I have renal artery stenosis, and this is my diagram. If renal artery is narrow, this is stenotic here, it is narrow here. So naturally, blood flow to my right kidney, it's my right kidney and right renal artery is narrow, so blood flow to the right kidney is less. If blood flow to the right kidney is less, then naturally what will happen? That GFR will be less because it is narrow, blood flow is very less, so glomerular pressure is not maintained and glomerular filtration is less, and if GSR is very less, this kidney has a risk of failure. Now how this kidney will protect itself, how this kidney will defend itself? It will do a special defense mechanism that when it is having low blood flow due to stenosis, this kidney will release a lot of renin. And this renin, as I told you previously, how JuxtaGlomerular apparatus will be activated, release a lot of renin, and renin will go to the blood, convert more angiotensinogen into extra angiotensin 1. Extra angiotensin 1 passing through the lungs will be converted into extra angiotensin 2. So in these patients' blood, they are having extra amount of angiotensin 2. This extra amount of angiotensin 2 will work specially on the efferent arteriole. This extra amount of angiotensin 2 will work on the efferent arteriole. So there will be intense constriction in the efferent arteriole. And if there is less blood coming from the afferent side, but efferent arteriole under the influence of angiotensin 2 become very narrow, then good glomerular pressures are maintained so that there can be good glomerular filtration and kidney keep on working. So this is how kidney defends itself when it is having renal artery stenosis, that kidney produces more renin, there's more renin, angiotensin, aldosterone excess stimulation, and more angiotensin 2 constrict too much its efferent arteriole so that GFR can be maintained. Now, if you give to such person angiotensin converting enzyme inhibitors, what will happen? This kidney cannot defend itself. How? That when you give angiotensin converting enzyme inhibitor, even though this kidney will be producing, this kidney with renal artery stenosis will be producing more renin, but angiotensin 1 cannot be converted into angiotensin 2. And as angiotensin 2 level will be less in the blood, is that right? Angiotensin 2 level will be less in the blood, right? Then of course efferent arteriolar constriction cannot be maintained. Efferent arterioles will dilate and glomerular pressure cannot be maintained, GFR will become dangerously down and renal failure will be precipitated. Is that right? Am I clear too? Then there is one more drug, spironolactone. It also works on this system. It binds with the aldosterone receptor. You remember I told you aldosterone is like this, and here is the receptor of aldosterone, right, which can activate the genes. Now, spironolactone is structurally similar to aldosterone. Spironolactone is structurally similar to aldosterone, and it binds at the site where aldosterone should bind with the receptor. And when spironolactone bind here, then aldosterone cannot bind there, right? Now, normally aldosterone bind and stimulate the receptor, but spironolactone bind with the receptor but does not stimulate the receptor. So when spironolactone is binding with the receptor, it does not allow the aldosterone to work and receptor become non-functional and occupied with spironolactone and not available to aldosterone. So aldosterone mediated actions on the principal cells are lost. And when aldosterone mediated actions on principal cells are lost, principal cell cannot retain salt and water, and salt and water will be wasted and blood pressure will go down. Then one more drug which work on this system is a drug which bind with the angiotensin 2 receptor. The drug which bind with angiotensin 2 receptor is called losartan. And there are many other drugs now they are having in the same group. These drugs are called angiotensin 2 receptor blockers. You can understand very easily that if you give a patient losartan or related drugs, what will happen? Angiotensin 2 receptors will be blocked, and angiotensin 2 mediated venoconstriction cannot be maintained with venodilation, and angiotensin 2 action on the arterioles is lost, arteriolodilation, so it will bring the blood pressure down. Then of course if you are given the losartan, then angiotensin 2 receptor on zona glomerulosa cannot be stimulated by angiotensin 2 and aldosterone release will be also reduced, right? So losartan is a drug which work on angiotensin aldosterone axis, and at what site it work? It work on the angiotensin 2 receptors, block the angiotensin 2 receptors, right? So that angiotensin 2 cannot mediate its action. Again, let me repeat. If you want to fail the angiotensin aldosterone axis or system, number one, you can give captopril and related drugs, angiotensin converting enzyme inhibitors, so that angiotensin 1 cannot convert into angiotensin 2. Or you can give losartan so that angiotensin 2 cannot work on the receptor. Or you can give spironolactone so that if angiotensin 2 has released the aldosterone should not be able to work. Now we talk about few other blood pressure regulating mechanisms. Another blood pressure regulating mechanism is chemoreceptors, right? And there are two types of chemoreceptors. Chemoreceptors. There are peripheral chemoreceptors and there are central chemoreceptors. Peripheral chemoreceptors, and there are central, which are present in central nervous system, central CNS chemoreceptors. Now, peripheral chemoreceptors are present, let's suppose here is your heart and here is your aorta. Peripheral chemoreceptors are present in the, please don't confuse baroreceptors with chemoreceptors. Baroreceptors are present in carotid sinus and aortic arch, and baroreceptors are sensitive to the blood pressure changes. Chemoreceptors are present in the, what is this? Carotid body. This is called carotid body, and here there may be aortic body. So this is carotid body, that is carotid body. It is not carotid sinus, carotid body, and other is aortic body. Now chemoreceptors are actually sensitive to, these ones especially are sensitive to partial pressure of oxygen. They are mainly responsive to partial pressure of oxygen, right? And they are very less sensitive to partial pressure of carbon dioxide and least sensitive to pH. So peripheral chemoreceptors are very, very sensitive to partial pressure of oxygen, and central chemoreceptors are more sensitive to partial pressure of carbon dioxide and pH. Now, when in your blood oxygen, partial pressure of oxygen is dropping, these chemoreceptors fire. These chemoreceptors fire through the 9th nerve and 10th nerve, and these neurons take information to the central nervous system. And then what really happens? This is your circulatory system. So whenever your partial pressure of oxygen in the blood becomes very low, the low partial pressure of oxygen or hypoxemia is sensed by the carotid body and aortic body through 9th and 10th nerve. They inform to the central nervous system. And in the central nervous system, now this is again to the medulla, pons and medulla. You remember that in the medulla there was tractus solitarius and the cardioinhibitory area, right? The cardioinhibitory area which was giving vagal outflow, and then there were cardiostimulatory area which was leading to sympathetic outflow for cardiostimulation through sympathetic ganglion, and there was vasomotor area, right? And this was also giving sympathetic outflow to the veins and sympathetic outflow to the arteries. We have discussed in the beginning of the lecture in detail. Now what really happens, that carotid body and aortic body, which are very sensitive to low oxygen, they action information to the tractus solitarius, right? And tractus solitarius orchestrate or alter the parasympathetic and sympathetic output in such a fashion that cardiac output should increase and sympathetic output should increase. Exactly how? That this will inhibit, tractus solitarius will inhibit the vagal outflow, it will stimulate the vasomotor center and cardio stimulation. And when vasomotor center and cardio stimulation is there, sympathetic outflow is increased and cardiac output goes up, arterial and venoconstriction occur, blood pressure goes up, right? So let's summarize it, that we are having peripheral chemoreceptors and we are having central chemoreceptor. First we'll discuss about the peripheral chemoreceptors. They're very, very sensitive to the low oxygen, but peripheral chemoreceptors are not so sensitive to the low pH, or they're not so sensitive to high carbon dioxide level. So you can say peripheral chemoreceptors are mainly oxygen sensors, right? Whenever oxygen level in the blood is low, they stimulate the central nervous system in such a fashion that there is intense sympathetic outflow, so that cardiac output should be more. An advantage of this more cardiac output is that more blood will be passing through the lungs, so that oxygenation should become better. But now we have to understand the central chemoreceptor. Also, central chemoreceptors are special areas which are present within the medulla, right? Central chemoreceptors are specialized area which are present within the medulla near the fourth ventricle. This is central chemoreceptors. Now what is the function of this chemoreceptor? These chemoreceptors which are centrally present are extremely sensitive to the proton concentration and partial pressure of carbon dioxide. Actually, what partial pressure of carbon dioxide is doing, that if in the central nervous system partial pressure of carbon dioxide goes up, then naturally it will fuse with the water, and what will happen, that in central nervous system carbonic acid level will go up, and that will dissociate into bicarbon proton, and this is the proton which really drives the central chemoreceptors. So you can say central chemoreceptors are driven by the proton and peripheral chemoreceptors are driven by the oxygen. When protons stimulate these chemoreceptors lead to intense, this is now very important to understand, central chemoreceptor lead to intense sympathetic as well as parasympathetic activity. The central chemoreceptors, when they are stimulated, they stimulate the vagal outflow as well as especially vasomotor outflow. So again, this is extremely important point, that up to now what we were discussing, that peripheral chemoreceptors stimulate the sympathetic outflow, but central chemoreceptors stimulate sympathetic and parasympathetic both activity, right? And if parasympathetic activity is too much stimulated, that will produce negative chronotropic action. So heart rate goes down. And when sympathetic activity is too much, the sympathetic activity on the heart is nullified by the action of vagus, but sympathetic activity on the veins and arteries takes the blood pressure up. So what really happens in these patients, which have severe stimulation of central chemoreceptors, they develop rising blood pressure. They develop rising blood pressure with falling pulse rate. Let me explain this thing, because this effect is called Cushing reaction. What is Cushing reaction? Cushing reaction is seen in the patients who have rising intracranial pressure. Cushing reaction is seen in the patient who are having rising intracranial pressure. Let's suppose there is a person who has intracranial tumor or mass lesion. If that tumor or mass lesion is expanding, then pressure in the cranial cavity becomes very high. And when pressure in the cranial cavity becomes very high, then cerebral vessels, cerebral circulation is impaired, because cerebral vasculature is compressed with high pressure. Again, a person develops a mass occupying, space occupying lesion in the central nervous system. As this lesion keep on expanding, then pressure in the cranial cavity become very high, and when there is raised intracranial pressure, what is there? Raised intracranial pressure. When there is raised intracranial pressure, that will lead to compression of circulation in central nervous system, and oxygen will not be reaching the central nervous system, and carbon dioxide will be accumulated in central nervous system. Am I clear? Or you want me to draw a proper diagram? Okay, I will draw a diagram for you to explain this thing. Look, here is a person, and this unfortunate person develops a very big tumor. If he is developing very big tumor, then it means the space occupying lesion, and this space occupying lesion is leading to raised intracranial pressure, because cranial cavity is a closed surface area. So when tumor is growing into that, pressure in the cranial cavity become very high. When pressure in the cranial cavity become very high, do you think then cerebral vessels can perfuse the central nervous system well? Can blood flow can be maintained in such a high pressure system? No. So that will lead to reduced cerebral blood flow, or blood flow is reduced to the all central nervous system. When blood flow is reduced in central nervous system, that will lead to accumulation of carbon dioxide. The partial pressure of carbon dioxide increases in the central nervous system. This carbon dioxide will fuse with the water in the central nervous system, and of course carbon dioxide plus water will make H2CO3. You know, carbon dioxide, rising carbon dioxide fuse with the water, they convert into H2CO3, and that releases bicarb and protons. These protons, which are generated within the central nervous system due to high level of partial pressure of carbon dioxide, they stimulate the central chemoreceptors. These are the central chemoreceptors, and these are stimulated by the rising proton concentration. Right? These chemoreceptors will lead to powerful increase in vagal output, plus at the same time there will be intense increase in sympathetic output. Now look, what really happened to this person with space occupying lesion? Of course, he will develop headache. With that, when vagal outflows, parasympathetic and sympathetic both are simultaneously overstimulated. Normally in the body what happens, if parasympathetic activity is more, sympathetic goes down. Or if sympathetic activity is up, then parasympathetic goes down. This is one condition in which sympathetic and parasympathetic both activity are very high. Now when vagal activity on the heart is very high, then vagal activity has negative chronotropic action on the heart, and heart rate goes down. So there is falling pulse rate. Patient has falling pulse rate. At the same time, when sympathetic activity is increased, the cardio stimulation is inhibited by the vagus, but sympathetic stimulation of venous system and arterial system lead to increased blood pressure. So this patient has severe headache due to space occupying lesion, plus he has progressively falling pulse rate and progressively rising blood pressure. And severe parasympathetic activity may also produce projectile vomiting. This autonomic disturbance may also produce projectile, very severe vomiting, right? And another thing, when intracranial pressure becomes very, very high, it compresses the retinal veins. So blood cannot be drained well from the retina, and a retinal artery keep on taking the blood to the retina, but retinal vein cannot bring the blood out of retina. So what really happens, that optic disc become swollen and it become edematous, and we call it papal edema. Papal edema. Let me explain exactly how papillary edema occurs. When you have raised intracranial pressure, then what really happens, let's suppose this is your eyeball and here is, now this is retinal fibers and this is optic nerve here. Now what really happens, that optic nerve has a dural cover on it, and there is this is the area which is basically having CSF. Now retinal artery enters into optic nerve and supplies the retina, and retinal vein, the blood from here drains back and through the retinal vein it comes out. Now the point which you have to remember, that retinal artery and retinal vein both pass through subarachnoid space in which there is CSF. This point, retinal artery is passing through subarachnoid space, here retinal vein is passing through subarachnoid space. Now what really happens, when you have a tumor in the brain, right, pressure in the central nervous system pressure in the intracranial cavity become very high and CSF pressure become high. If pressure of the CSF is very high, CSF will compress the vein but not artery, because artery is a high pressure system, retinal artery is a high pressure system, and retinal vein is a low pressure system. So when intracranial pressure is high, right, CSF pressure also become high, then as retinal artery passes through subarachnoid space, CSF cannot compress the retinal artery, but rising pressures of the CSF and intracranial cavity can press the retinal vein. So retinal artery keep on supplying the retina, but retinal vein cannot drain the retina. So edema develops in retina, and this edema which develops in retina, this become maximum around the optic disc, right, and margins of the optic disc will be blurred. Let's suppose here is optic disc, right, and margins of the optic disc are usually sharp, but in this person where edema is developing around the optic disc, as venous drainage is impaired, so this margins will become blurred, and this condition is called papillary edema. So if a patient has raised intracranial pressure, he has developed headache, he has rising blood pressure due to sympathetic overflow, he has falling pulse rate due to parasympathetic overflow, he has projectile vomiting due to autonomic disturbances, and he has papillary edema because outflow venous system of the retina is compressed. Now there is a small role played by antidiuretic hormone in maintenance of blood pressure. Let's suppose if someone is having severe hemorrhage, right, and blood volume becomes significantly low, right, then the posterior pituitary will release the ADH hormone, which is also called vasopressin hormone. But you have to remember that ADH is synthesized in the hypothalamus by supraoptic nuclei, right? ADH is synthesized in the hypothalamus by the supraoptic nuclei, and from there neurons project their nerve endings into posterior pituitary substance, and in the posterior pituitary within the nerve endings ADH is stored, and from there ADH is released when there is hyperosmolality in the blood or when there is significant loss of blood pressure. Once ADH is released, it has two functions. One important function is ADH will work on the V2 receptors on the last part of nephron. V2 receptors are present on the epithelial cells of the last part of the nephron, that is distal convoluted tubule, collecting tubules and collecting duct. And when these cells are acted upon by the ADH, these cells develop more water channels, they present more water channels on the luminal side. So more water is reabsorbed from the lumen of the nephron to the interstitium, right? So we can say that ADH act on the last part of the nephron, make it highly permeable to water, so that water from the luminal side can shift to the hyperosmotic medullary interstitium. And in this way, in patient who is bleeding, high amount of ADH help in retention of the water. And if this water is retained in the body and not wasted in the urine, this water will try to maintain the blood volume so that venous return can be maintained and cardiac filling can be maintained, cardiac output can be maintained, and blood pressure can be maintained. Second thing, ADH in high concentration can also produce arteriolo and venoconstriction. And you know, when there is venoconstriction, venous return to heart is increased, cardiac filling is increased, and cardiac output and blood pressure is supported. In the same way, ADH in high concentration can also constrict the arterioles. And when arterioles are constricted, that will increase total peripheral resistance, which will support the diastolic blood pressure. Now, one of the another very small factor in regulation of blood pressure is atrial natriuretic peptide. But you have to remember, as I told you, ADH is released more when there is hemorrhage, but atrial natriuretic peptide is released when body has excessive volume. For example, if you have excessive volume, then venous return to the right heart will be increased, then atria, right atrium especially, it will release atrial natriuretic peptide. This atrial natriuretic peptide acts on the kidney and it produces natriuresis, that is loss of the sodium. If there is loss of the sodium, of course with the sodium some water will be lost. In this way, atrial natriuretic peptide lead to salt and water into urine so that it deloads the extra volume in the body. And if there is a high volume in the body and that is taking the blood pressure up, atrial natriuretic peptide will be released in excessive amount and force the kidney to lose some salt and water so that blood pressure can be brought down. Another thing which high concentration of atrial natriuretic peptide can do is vasodilation, and that also helps to bring the blood pressure down.